Okay. Now time 8 o'clock.
ايوه اتفضل دكتور.
Okay. Okay. Good morning, everyone. Firstly, it's a very privileged and honorable moment for me to be here with you. Firstly, I would like to introduce myself to you all. My name is Mehmet Kaya. By the way, English is not my mother tongue. If I make any mistakes, please accept my apologies in advance. I would like to be clear, understandable, coherent, because this topic a little bit complicated, but as much as I can, I would like to be simple to understand better. My name is Mehmet Kaya. I am working in Al Musa Specialist Hospital for the last 1.5 years. And actually, this topic can be found in many books. I will give some pictures and details, but at the same time, I would like to transfer my experience from field, from my experience from time to time. It would be better. Surgical management of aortic insufficiency and valve sparing surgery. Before I start this conversation, I have to say something. Before doing this surgery, I mean, if we put this surgical modality into our practice, firstly, we have to know, we have to understand at the same time aortic valve surgery, aortic root enlargement, types of aortotomy, Bantal surgery, I mean aortic root surgery, and then we can dare to do this surgery, because you will see from my slide there are many calculations, there are many things needs experience, but it is simple, it is straightforward if we know. Sometimes I will use my mouse cursor. Please, sometimes I will follow my arrow. Firstly, we should know anatomy of the aortic root, because we will use that anatomic information in every type of aortic surgery. Of course, you know better than me that structures, but there are some calculations. For example, if we put in the future sutureless valve, for example, we have to know sinotubular junction and aortic annulus diameter ratio. If we do, for example, valve procedure, I will tell later, we have to know aortic sinus diameter. I mean, we have to know every detail. By the way, this arrow is showing aortic annulus, but in the field, in the reality, we are not using that area. Sometimes cardiologists are measuring here, for example, they are saying 22 to 25 millimeters, but please always, we have to make them understand, I mean, they understand we need this part. This part, valve is sitting, or we are repairing at this level. Another anatomical picture, I am giving too much importance for this picture, because if we know every detail in this picture, it means aortic surgery will be straightforward, because we know what we are doing. Around aortic valve, 45% of aortic annulus is related to muscular. I mean, this section. We need to know why. For example, if we do Hocum surgery, we are removing muscle from here, and we are not going this part to this part. And if we do aortic root enlargement, again we have to know this is Nunes, this is Manukian, this is modified Manukian, this is Nix, and this is atrioventricular node. Something like that. And please notice aortotomy. Normally, in aortic valve replacement surgery, we are doing J-shape aortotomy, J-shape. But if we do aortic valve repair, aortotomy should be transverse. Otherwise, we can do perfectly well aortic valve repair, and we can test with saline, no leakage. After closure of the aortotomy, cardiologists can say that you have eccentric aortic valve regurgitation, because our J-shaped aortotomy after the closure, it can disturb our coaptation reserve. Because of that transverse aortotomy, I'm summarizing. And another point, in normal aortic valve replacement surgery, we can open aorta even 2 centimeters above from RCA orifice. But if we do aortic valve repair, in my opinion, it should be maximum 1.5 point above aortotomy. In this way, exposure will be very good. And another point, some surgeons preferring total aortotomy. In my practice, I'm not preferring. In my opinion, no need to open to cut aortotomy. I mean, totally. Etiology, again, you know better than me. There are many types of etiologic factors: degenerative connective tissue disorders, bicuspid aortic valve. This is a little bit important. Dissections. I mean, why bicuspid aortic valve is a little bit important? Because we need to know some details about that. Dissection, endocarditis, trauma, and tumor. And if we set out to do aortic valve repair in our surgical repertoire, we need to understand lesion is related to which structure of the heart. Lesion is related to annulus or commissure or leaflets or aorta directly. If we understand before surgery, it means we may have a plan. There are actually 3 or 4 classifications about aortic insufficiency and valve sparing surgery. I am actually giving importance for, especially in Carpentier classification and Al-Kahuri classification, because they are making simple. And if we understand, yes, as I said before, we can have plan for the surgery. Firstly, according to Carpentier classification, type 1 aortic insufficiency, as you can see, there is central jet. This is the most straightforward actually type. And in type 1, there is annular dilatation. Because of that, coaptation surface is decreasing, and then we have central aortic regurgitation. And it can be leaflet perforation or vegetation. Type 2, there is eccentric aortic failure due to leaflet prolapsus or commissure detachment. Type 3A, rheumatic. Type 3, again, not rheumatic, but very similar, because type 3A restricted leaflet during the opening and closing. In my career, in my practice, in 1 minute, again, I would like to give some information from my field. It will be very beneficial. In my previous hospital, we started a program of not aortic rheumatic disease, mitral rheumatic disease repair. But according to guidelines, according to science, many scientific publications, in rheumatic disease, mitral repair or aortic repair actually not recommending too much. But all the time, we are seeing every kind of patients. Sometimes some patients are not suitable for using anticoagulant, and we had to do repair, and we published in Texas Heart Journal because we thought we changed something. We proved even rheumatic disease, we can do repairs. But after some years, after 5 years, our repair patients started to come again stenosis or regurgitation. But at the same time, we already started aortic valve repair in rheumatic disease. Again, our results were good, but we didn't publish because after some years, again, they started to come. In my honest opinion, in rheumatic disease, aortic valve repair, we need to think twice, actually. Alcoholic classification, again, it's very similar. They are describing aortic ascending aorta, aneurysm, central jet, eccentric jet. Actually, a little bit seems to be complicated, but only I will add information from alcoholic classification. As you can see, there is subcommissural annuloplasty. They are recommending strongly. Again, in my practice, I'm doing the subcommissural annuloplasty in patients with annular diameter is greater than 25 millimeters. I'm sizing the aortic annulus. And by the way, I'm telling information from my experience, but all information is accordingly compatible with the book, scientific publications. But why I'm telling this? Because some they can prefer subcommissural annuloplasty if it is larger than, for example, 28 or 30, or maybe they are not doing. But in my practice, always I am doing, because you need to have some plan. If you have plan, it is easy to do it. I am using valve sizer if aortic diameter is greater than 25 millimeters, and then I am doing valve sparing surgery at the same time subcommissural annuloplasty. In type 1A, no need to tell all of them. It's very similar to before one, but just I would like to add something. If we do aortic valve repair or ascending aorta replacement, some extra techniques we can use actually, because especially if we are changing, if we are replacing ascending aorta, but not between aortic annulus and sinotubular junction. It means we are leaving some ascending aorta part, but there is ascending aorta aneurysm. It means aortic wall is pathologic. It means after some years, remnant aortic wall again can go ascending aortic aneurysm. And you can imagine there is a patient, they are coming to you, redo case, they replace before ascending aorta, and then there is somehow aortic insufficiency and remnant aortic aneurysm. This surgery, of course, will be challenging. Because of that, we may need some techniques. What I am doing, I am calling it, I published this one in vascular surgery journal. I'm calling it lifesavers. We can use some remnant aorta to support remnant aortic wall. Because of that, I am calling it lifesavers. But generally, I am not inclined to do just ascending aorta replacement. If I have any doubt, of course, I'm excising, I'm removing all aneurysmatic sections. There is another classification, Lansac classification. In my opinion, no need to talk about that too much. Why we are doing aortic valve repair? By the way, my last 10 slides directly will focus on valve sparing surgery. Why we are doing this surgery? Because young patients really needs aortic valve repair or valve sparing surgery. And in this, thanks to this surgery, we are preventing from rupturing and dissection of the aorta. We are protecting structure of valve restoration, and the patient avoids prosthesis related complications such as endocarditis, thrombosis, reoperation, and prosthesis patient mismatch. We need to obtain leaflet mobilization during this surgery. And the most important thing, we need to have from 2 to 6 millimeters coaptation surveys. As you know, in mitral repair surgery, 15 millimeters always, we need to have 15 millimeters coaptation zone, coaptation surveys. Actually, it is valid in aortic surgery. Again, we need to have from 2 to 6 millimeters coaptation reserve. Another point, annular stabilization. There is 2 kinds of stabilization technique. One of them annular stabilization, the other one commissural stabilization technique. I told before, if the diameter is greater than 25 millimeters, I am applying both of them sometimes, and I will give detail. Aortic valve repair techniques. If the problem is related to annular dilatation, and if there is central regurgitation, what we are using? This is annuloplasty from inside of the aorta. There is annular dilatation, and there is central jet. But in my practice, I use this technique, but this technique, it sounds well thought out to me now. I mean, from the picture, it looks perfect, but in the reality, we are doing this technique, and then we are disturbing, we are affecting coaptation zone, because aortic valve, not every part of equally. Because of that, I am not using this technique. Actually, honestly, what I am doing, I am using 2-0 sutures, and from aorta, from outside of the aorta, I am passing. Firstly, we have to separate. We have to make free right coronary artery orifice and left main coronary artery orifice, because that slick suture will go under them. But you need to know there are two kinds of. Some of them they are doing from inside, but I am using silk suture from outside aortic wall, and this is my again routine resuspension sutures. Recently, I started here Ozaki procedure in Saudi Arabia, and I noticed that nobody is doing in Ozaki procedure, for example, resuspension sutures. But some people can see Ozaki procedure not replacement, not repair, as repair. But in my routine practice, if I am doing aortic valve repair, always I am using resuspension sutures routinely, because I'm believing that it is increasing coaptation surveys again. This is subcommissural annuloplasty suture plane. We will see later. Yeah, subcommissural annuloplasty suture. Again, we are using 2-0 polyester suture, same valve suture. Routinely, we need to use 12 subcommissural annuloplasty sutures. For each commissures needs 4 sutures. We need to know it again. If we have plan, we can do it easily. This is leaflet perforation. Again, in the picture, it looks very easy, but not every patient is like that. For example, I published this one. We need to, our plan, this case, mitral and aortic infective endocarditis, and our plan was to repair mitral and aort, but there was, as we can see, there was 3 holes in each leaflet of the aort, and there was a drop lesion in the anterior leaflet of the mitral wall. Because of that, we changed directly. But if there is one hole, yeah, we can repair. Again, vegetation is the most easiest part of repair technique, because we are removing local vegetation, and then we are using all repair techniques. Leaflet prolapsus, it is causing eccentric aortic jet. It's like that, and we are duplicating 5-0 Prolene suture. I'm using this one, but I'm using at the same time very small plagiated like that. The aim is to decrease the, but again, we have to be very careful. If we if we behave liberally, if we duplication too much, again, we are causing central jet. Firstly, we can use very small, part of aortic leaflet, and then saline test, and then again, we can add something. Another application, or they're calling free margin resuscitation. I'm not, again, recommending this technique, but of course, you can test, because after this technique, we are retracting aortic leaflet. Again, we are causing, especially we are affecting Mercedes emblem. We have central jet or eccentric jet. This is commissuroplasty, trimming, pericardial repair. Yeah, we used too much in rheumatic disease. As I said before, after the surgery, everything is okay. Sometimes patient is pushing us. Patient is coming, for example, they are saying we want repair. And I am telling them, yeah, we can repair aortic valve, but I'm telling the patients, you need to know after 5 years later, again, you can have some kind of aortic regurgitation because your disease is ongoing process, rheumatic disease, because it is ongoing process. And I'm expecting from them, okay, replace my valve, but no, they are not accepting. People always inclined to repair. Of course, always I'm applying respect, then reject theory. But my practice really, and scientific publications showing that if you are doing aortic valve repair in rheumatic disease, after some time, again, you can have aortic regurgitation due to ongoing process. Yes. I told before, if the problem is related to ascending aorta, we are changing ascending aorta. But if we have any doubt from about remnant aortic wall, we need to change it. Because in my practice, again, I saw many times, okay, this guy is coming, or lady is coming, about redo case, they changed before ascending aorta, they left remnant aortic wall, and then now you have aortic regurgitation, you have redo case, you have here ascending aorta aneurysm. Again, I published this one because I wanted to emphasize this one, and I called it aneurysmal fate of residual aortic root, because and then you are going to bundle surgery, but the first surgery, if first surgery replaced all aneurysmal plane, of course, I will not call aneurysmal fate of residual aortic root. Bicuspid aortic valve repair. Again, this is a very special topic. My suggestion, repair technique, firstly, you should apply tricuspid valve aortic surgery, and then you can go for bicuspid aortic valve, because in patients with bicuspid aortic valve, at the same time, their ascending aortic wall is pathologic. What I am meaning, patients can come with aortic regurgitation. Ascending aorta can be normal, but after some years, again, patients can come with ascending aorta aneurysm and aortic insufficiency, because as you know, 2% of patients with bicuspid valve in their life, they are going for aortic dissection, and some repairing technique again cannot be promising. Because of that, after you have experience with all aortic valve repair technique, and you can go for bicuspid aortic valve. Again, in my practice, I have some plan for repair, but I'm generally doing Ozaki procedure, or if patients wants metallic valve, I'm using metallic valve, because you can repair bicuspid aortic valve, but you should make sure 100% it will not cause problem. That valve procedures, some patients ascending aorta is normal, aortic valve you are repairing as aortic valve, but you have doubt about non-coronary. Generally, patients will have an aneurysm with relate to non-coronary part of ascending aorta, and then we are excising, follow my arrow, we are excising non-coronary segment, and then we're extending graft here. Again, after the repair of aortic valve, that can disturb our coaptation area. Because of that, not wedge directly, as you can see, we need to excise like partial David or Jakob procedures. I will tell later. Otherwise, if we do like wedge like that, if we do like that, we can cause some kind of regurgitation. There are two modalities, Jakob and David procedures, valve sparing root surgery. But as you know, anymore we are not doing Jakob procedure, because Jakob procedure, after many years, we saw again patients can come 7% in 10 years with aortic regurgitation. Because of that, reimplantation David procedure also is my favorite, and subcommissural annuloplasty technique, the last modality. There are many kinds of, but I will not give, because we need to know which one we are using in practice. This is Jakob modality, just 2 sentences, 3 sentences, you can understand better David procedures. We in Jakob procedures, we are excising all ascending aorta aneurysm. We are, if there is aortic regurgitation, we are repairing. If there is no aortic regurgitation, after we excised all aortic aneurysm, and then we are separating, of course, left coronary artery, left main, and RCA, and then in this like we are putting our graft, and we are implanting orifices like dental surgery. No need to say about Jakob technique too much, actually, but maybe we can add why we abandoned to do Jakob technique, because it's anatomic and physiological, by the way, but the problem, lack of annular stabilization, and David technique is completing Jakob technique about lack of annular stabilization, and it is not suitable in patients with connective tissue disorders. It's very important, because we have many Marfan syndrome patients. David technique, yes, this is my practice. This is current practice in the world, and in my opinion, after you have aortic valve repair experience, aortic valve surgery, you need to because it's very enjoyable, by the way. And Day2 procedure reimplantation takes it's cool surgery, very enjoyable. Patients always will be happy because why? You didn't change patient's valve. If you change patient's valve, but there is no regurgitation, but you need to have justification for that. In the surgery, step one, firstly, we are excising all, of course, we are cutting aorta totally, and then we are excising all ascending aorta aneurysm, but we are leaving here. Some people, they are seeing 2 millimeters, some 5 millimeters. I am leaving actually 5 millimeters because I am putting the suture liberally. And then aortic root, we are separating. By the way, I have time or not? Yeah, I have time. And please notice these sutures. These sutures, subcommissural annuloplasty stabilization sutures. Again, I told you before, we are using 12 because if we count 1, 2, 3, 4, 5, but in my current practice, I'm using 4, maybe the other part of needle. And after that, we are passing this external suture, I mean, directly from the graft. And as you can see, all aortic wall and just we are keeping outside coronary arteries. Graft is sitting. Now all aortic wall is going inside graft. Red arrow, please. And this one, these 3 sutures, I mean directly from commissure, from inside to outside. You will understand better, no worries. Because I will emphasize all steps again. And valve sizes, because graft diameter selection is too much important. Why? Because we can do like that, and then this part will go inside, and then you are noticing that graft diameter is a little bit small, and if we are putting this inside, and then we can see there is plication because it is narrow. Because of that, we are detecting, we are deciding, we are using valve sizer to detect real diameter, and then we are selecting graft plus 4 millimeters. For example, we measured 25 and or 26. We are using 29 or 30 graft. It should be greater than 4 millimeters. As you can see, now all aortic structures will go inside, and we will see. And this diameter is again very important. We need to measure. I am measuring all leaflets, and then I am marking graft accordingly. And we need to know height of commissures. Again, I will give details. It means we need to have 3 things. Firstly, graft diameter should be greater than 4 millimeters after size of the aortic diameter, and every leaflet diameter we need to know. Generally, non-coronary leaflets 2 millimeters or 1 millimeters or 3 millimeters, maximum 3 meters is greater than the other ones. Generally, left and right coronary leaflets generally equally. And height is very important. 3 things, that's all. And then it is straightforward. By the way, subcommissural annuloplasty sutures, not hemostatic sutures. Because of that, all surgeons need inclined to use too much, 15 sometimes. No, we will use, this is fixation. Because of that, just we will use 12. But this part, yes, our continuous hemostatic suture line, I am using for 0, 20, sometimes 21, sometimes if there is enough space, 26 millimeter needle. And this is important. After suturing, again, I'm using hook. Is there any space or not? Because after the removal of the cross clamp, it is nearly impossible to put extra sutures from outside, because we will not see this plane from outside. And then we are reimplanting aortic orifices. But this orientation is very important. If you change this orientation, and then you may not, sometimes you may not put our left main coronary artery orifice here. I mean, left coronary artery orifice should be face to face. Again, that sinus. Right coronary orifice should go face to face. Again, that from with that sinus. And I am using 5-0 Prolin suture for this anastomosis. Yeah, this is the measurement I'm marking here, and then I'm measuring the top of the commissure, and then again I'm marking in the graft. It means we will measure all commissures length and then height. Actually, steps are very obvious. If we know steps, of course, if we obey instructions, of course we will do it, and we will not have aortic regurgitation. Even you will not curious about T will show what. I mean, because you know what you are doing, and you will test your valve with saline. Again, this is how we are measuring, just based off the leaflets, and then this is commissural plane. We are measuring here, and then we are marking inside the graft, and we are fixing this commissure like that. This is the last appearance. It means we are measuring height, we are measuring length, and graft size should be larger than 4 millimeters aortic annulus diameter. That's all. There are many types of Day2 procedures. No need. Day2 procedure, it provides annular fixation, annular stabilization. It supports aortic wall. There is low risk of bleeding, because subcommissural annuloplasty sutures are not hemostatic, but somehow, again, they are playing hemostatic suture plane. And very acceptable long-term results compared to Yacob procedure. And acceptable results, we have acceptable results in patients with connective tissue disorders. And some tips and tricks: patient selection. I mean, graft selection is very important. Again, I'm emphasizing commissure length is important. And another point, coronary buttons, anastomosis, the most important thing, because if you cause obstruction after removal of the cross clamp, you will have ventricular fibrillation, distension of the heart, or some problems. I will show how we are doing this. And if there is leaflet prolapsus during the surgery, again, of course, it should be repaired. Annulus diameter, if annulus diameter is greater than 32 millimeters, again, Day2 procedure may not be suitable. I mean, all the time, patients, of course, they will have some kind of mild or from mild to moderate aortic regurgitation. And if there is moderate aortic regurgitation, of course, you need to apply. And unstable hemodynamic, I mean, if the patient is emergent, again, I'm not using, or also scientific publication, they are saying no need to this surgery. Low ejection fraction, mechanical mitral valve, usage of oral anticoagulants. Yes, Button, we need to leave aortic wall here a little bit more than here. And in this way, from the profile, we will see this anastomosis like that. this one, because we are kinging this one. But if we use, and if we don't leave too much aortic wall, and it will see, it will be seen like that, and there is no obstruction, because this remnant aortic wall is too much, and we are kinging that just directly orifice of the left main. Even patients can come off from CPP machine, even you can discharge, but after some time patients can feel some kind of pain. Because of that, the upper part of the left main aortic wall should be more than the inferior part. Again, same. Thanks. I hope I finished my conversation. I hope I became understandable. If you have any question, of course, I can reply. Thank you so much, by the way.
Thank you, Dr. Mohammed. This is Murtada. I'm a final year resident from Breast Cardiac Center. Thank you for your time and effort. Can you please elaborate more on the sizing of the graft?
Okay. Yeah. Firstly, we are doing aortotomy totally, and we are using sizer, aortic valve sizers, like as if we are changing aortic valve. If sizer, for example, 20 is showing 26, sizer number 26, we need to use 30 millimeters more. You are plussing, it means 30. If we are measuring 21, we are using graft 25. Sometimes we can use, because it is changing from company to company. For example, sometimes sizers, single numbers, 21, 23, 25. Sometimes sizers is going 20, 22, 26. Some grafts, sometimes they are going 20, 22. But if you have any doubt, always I'm using 4 millimeter rule. But again, you can use 3 millimeters. And we measured diameter, for example, let's assume 21. And I am selecting graft 24. Because why? Because all aortic structure will go inside the graft. If diameter is equal, that aortic valve will be plicated naturally, and that plication will cause eccentric aortic jet. If your graft size is greater than too much, this one, again, you will have central aortic regurgitation, like there is our aortic root dilatation, like there is ascending aortic aneurysm again. And the other sizing, height and length of the leaflet. Actually, we can ask how we are measuring length of the leaflet, because this shape is curved shaped. There is only one way actually, but if you don't have, of course, you can apply this rule. Generally, okay, you can use some silk suture, you can use some, and you can improvise your technique. But there is some special instruments, especially one-time usage. You cannot make you cannot use many times, but in Ozaki kits, I'm using Ozaki. We are measuring this length, but if you have some instruments, silk suture, many or other things, you are measuring length of the leaflet. Sometimes non-coronary leaflets is a little bit longer than the other ones, and based off the leaflets to commissure another, because we will use length of the leaflet, we will use height of the leaflet, and we will use graft selection. I mean, which size we will use. And we will mark 3 points. You see, we are passing this suture graft. But sometimes if we don't know height, you can fix this one, for example, 1.5 point. You can fix this one 2 centimeters. You can fix this one 1.5, 7, for example, 1.7 centimeters. It means aortic valve will not be same line because it should be equally have heights. We are marking graft from inside because we measured height, and this area again we measured length of the commissure. It means we know height, we know length, and we know graft size. For example, this one 21, this one should be 24, maximum 25. In this way, we are making this valve spinning root surgery like native one, because just we need to know 3 measurements and then we are applying. Inshallah, I became understandable now. I don't know. It's enough or not about graft selection. By the way, I will. Sorry, I will add something. I forgot something to do that. It is not related to your question, but every surgeon, and also I am applying glue after the surgery. But some glue, after 1 minute, they are changing its shape as solid. And then if we are applying around coronary arteries, please, we should be very careful, because sometimes that glue, again, that push coronary artery, because we already separated and there is no supporting tissue here, and glue sometimes can push left main coronary artery and right coronary artery, and then again we can cause some kind of obstruction. Again, this is very important. I experienced 3 or 5 times this issue. Because of that, I am applying very less around coronary arteries, because some companies, because sometimes hospitals, they are changing glue company, and you don't know the character of the glue after you apply. It should be soft, in my opinion. Because of that, I'm not using too much, but if I am using, I'm using very less. This was very important, because you are doing very successful surgery, and then your glue is causing biggest problem. I don't know if you have any question or not.
Because thank you for the really beneficial lecture. I enjoyed it actually. Just one question regarding Ozaki technique. So I attended a grand round one day in our hospital, I think Face of Specialized Hospital, and they mentioned that they are questioning the durability of Ozaki technique. So what is your comment about this? What is your experience about it?
Yeah, your voice was breaking up. If I'm not understanding well, please correct me. You are asking my experience about Ozaki procedure and opinion, right?
Yes, and the durability of the procedure.
Durability. Very good question. Ozaki procedures durability, unfortunately, 15 years ago was invented by Dr. Ozaki. And because of that, only we can talk about this procedure for the 15 years results. Some people, they are seeing Ozaki procedure as repair technique. Some people, they are seeing replacement. In my opinion, this is repair technique, but not important, that phrase. Durability is now promising much better than biological valve. But the problem, our results for 15 years. Because of that, but the problem, Ozaki technique, some patients in our practice, their aortic annulus is too much small and calcified, and their age around, for example, 55 or 60 years. And of course, if we don't do aortic root enlargement, or if we want use all aortic orifice, of course we can go for Ozaki technique. Durability, we can assume like directly biological valve. But Ozaki has some advantages. We are using all aortic orifice, the most important thing. And there is no, because some people, but we cannot prove, but immune reaction for other valves. But in this, in Ozaki procedures, there is no immune reaction and after biological valve, patient again need to use some oral anticoagulant, but Ozaki procedures no need. We are using acetylsalicylic acid. In selected patients, Ozaki procedures have too much advantages, but durability, and after Ozaki procedures, TAVI procedures, there is question mark. But the problem, according to guidelines, if patient wants biological one, class 1, there is class 1 indication. Because of that, for example, 40 years old lady or 35 years old lady, and she wants to have pregnancy, and she wants biological valve, you can apply biological valve or Ozaki procedures again, in my opinion, because 15 years durability rate, it's very similar biological one, and some publication says much better than. And at the same time, you are using other advantages. But the problem, Ozaki procedures is not common in every countries. Even in my practice, sometimes I'm warning, it's another issue, but I don't want to praise Ozaki procedures too much, because at the same time, Ozaki procedures have some not scientific disadvantages, but practical disadvantages. For example, I am warning our scrap nurse, please apply maximum 10 minutes glutaraldehyde, but sometimes he says now 11 minutes. Also, team should be familiar with everything, because you are applying glutaraldehyde 10 minutes, and then 60% of the muscle cells or cells of inside the pericardium viable. But if you apply 11 or 15 minutes, you are decreasing viable cells. It means you will affect the durability of the pericardium. It means flexibility will be not good after some time. Because of that, if the surgeon has any doubt, and if the surgical team is not ready to use it, biological one, first one, but after some time, in my opinion, again, Ozaki technique have too much advantages compared to biological one. We can use these advantages, but durability, if you apply all instructions, durability same, a little bit better than other valves, because at the same time, biological valve companies, they are developing themselves very well, especially now there is dry technology. That dry technology valves, also I am using actually, dry technology valves, they are very resistant to calcification. And even if you are putting, for example, I'm not recommending 19, but sometimes we have to 90 millimeters biological one, and you will have, for example, mean gradient 20, and even you have mean gradient 20. After 18 years, their results is very promising. But at the same time, Ozaki Techniques is developing themselves. Because of that, there is competition between them. According to based on the selection, yes, we can use Ozaki technique in selected patients. Durability, same, even better some companies. Because of that, there is no doubt about durability. The main problem, 15 years ago, Ozaki invented, and Ozaki doctor himself first 1,000 cases. That's the main issue. But now every country, many surgeons started to use it. We will see real durability rates. We will see real results within 5 years, in my opinion.
Thank you, Dr. Great.
Thank you so much for everything. It's an honor for me to be in Saudi Arabia, and I am transferring my experience now. I would like to be beneficial for this country and for you all, because I dedicated my life to residence in my country, previous hospital. I was working as a lecturer, and I was educated cardiac surgeons in every level. Because of that, really cordially, I can say that I am very happy, even if I am giving a piece of information. You cannot imagine my gratitude and my heart. Really, I am grateful to you all for this opportunity.
Thank you very much, Dr. Mehmet, for your amazing presentation, and hopefully we can see you in another occasion in the near future. Thank you very much. So we'll have 3 minutes break, and we'll continue with the next lecture, inshallah.
Okay, thank you so much. Have a nice day for all of you.
Dr. Nadir.
السلام عليكم.
السلام ورحمة الله. أهلا دكتور.
كيف الحال؟ الله يخليك.
You can start.
عليكم السلام.
Can you see my screen?
Yes, we can. Clear.
طيب، بسم الله الرحمن الرحيم. كل عام وانتم بخير يا شباب بمناسبة اليوم الوطني السعودي. And thank you for having me. To speak about tricuspid valve surgery in this course. Let's start with some facts about the tricuspid valve. It is the most accessible cardiac valve of all the four valves. It's the most accessible surgically. And surgery for the tricuspid valve requires isolation of the circulation from the right atrium. And annuloplasty is the commonest procedure performed on the aortic, on the tricuspid valve. We are dealing mostly with TR more than TS. TS is very rare situation, and it's mostly a concomitant procedure. Most of the surgery on the tricuspid valve is concomitant with either mitral or aortic or left-sided heart surgery. There are some peculiar facts related to the tricuspid valve, which might seem a little bit confusing, but they will be understood as we go with the presentation. You can see a situation whereby annuloplasty for the tricuspid valve is performed for mild to moderate TR in some situation, and on the other situation, nothing is performed in concomitant procedure while we have severe tricuspid valve regurgitation. Another situation is whereby there is a situation whereby tricuspid orifice is closed, a procedure called stance operations for those who are in congenital surgery. And in another situation, the tricuspid valve is totally removed to save the life of the patient. The tricuspid valve disease burden, we know that severe tricuspid valve regurgitation is associated with increased morbidity and mortality. The overwhelming or the majority of tricuspid valve surgery is performed during concomitant valve surgery. There are 1.6 million cases of moderate to severe tricuspid valve regurgitations in the United States who are not helped with surgery, telling you there is an unmet need for tricuspid valve treatment. And we'll know later why we have this redundancy in performing tricuspid valve surgery. The surgical anatomy of the tricuspid valve, being a tricuspid, it has 3 leaflets, anterior, posterior, and septal leaflet. Important relationship of the tricuspid valve include relationship of the conduction system, the presence of atrial AV node, the triangle of Koch. We know the boundaries of the triangle of Koch is formed by the base of the septal leaflet, the coronary sinus, and the tendon of Tedero. An important relationship of the tricuspid valve also is the aortic root, which is marked here by the star. A relationship which you cannot see here in this diagram is the right coronary artery, which is directly related to the annulus opposite to the anterior and posterior leaflets. Here is a morphology specimen showing on the right side video digital palpation of the tricuspid valve. Here it is demonstrating the relationship of the aortic root to the tricuspid valve annulus. Actually, it is very close to the anteroseptal commissure. And it's also by digital palpation, it demonstrates the fibrous skeleton of the heart. Also, the finger is sweeping in the annulus shows you the distensible part of the tricuspid annulus, which is the annulus opposite to the anterior and the posterior leaflets of the tricuspid valve. The left side morphology specimen shows the transparent leaflets of the tricuspid valve. And when you have transparent leaflets, means delineation or inspection of the hinge point between the endocardium and the leaflet is difficult. Sometimes it requires a special technique to know exactly where is your annulus. The tricuspid valve is the largest of all the 4 valves. It has an area of 7 to 8 centimeters square. It is the most apically displaced valve. It's D-shaped. The annulus is D-shaped, meaning it is non-planar. It's also a dynamic structure. It changes between systole and diastole by 30%. These are the anatomical relationships of the 4 cardiac valves. And please appreciate here the close relationship of the non-coronary sinus to the tricuspid valve annulus. Placing annuloplasty sutures right here can easily injure the aortic root and lead to consequences of bleeding or injuring the aortic valve. And at worst, you can get a dissection. The etiology of the tricuspid valve is divided into primary tricuspid valve regurgitation and secondary tricuspid valve regurgitation. We know that in surgery, mostly we deal with secondary tricuspid valve regurgitation. And in most of the cases, it is related to left side heart disease or pulmonary hypertension. Rarely it is related to atrial fibrillation or severe dilatation of the right atrium. Congenital causes of primary TR is related to congenital causes and acquired causes. Acquired, it's like the mitral valve. It can be affected by rheumatic heart disease, carcinoid, myxomatous degeneration of the tricuspid valve, and some of the congenital causes include Ebstein anomaly and double orifice tricuspid valve and some other congenital anomalies of the tricuspid valve. But 90% of cases that surgeons deal with is tricuspid valve regurgitation related to left side heart problem. How do we grade tricuspid valve regurgitation? There is more focus from imaging people to really stage and classify tricuspid valve regurgitation. They look into the regurgitation itself and they measure it. And they look into annular dilatation, even if there is no regurgitation. And also they look into coaptation mode, how much leafless coaptation the valve has, even if there is no regurgitation. And by doing that, they stage the pathology of the valve into stage 1, stage 2, and stage 3. Stage 1 is where there is no much tricuspid valve regurgitation. The annulus is not dilated, meaning annulus is less than 40 millimeters, and reasonable coaptation. Stage 2, mild to moderate regurgitation. There is annular dilatation and impaired coaptation. And stage 3, you have severe tricuspid regurgitation with annular dilatation and failure of coaptation. Taking these together, the tricuspid valve regurgitation is classified into mild, moderate, severe, and they have added massive and torrential. For our purposes as surgeons, severe and beyond is the same, is treated the same. So if you have torrential or severe, it doesn't matter for a surgeon, from surgeon perspective. If more than severe, it has to be taken care of. Surgeons in this spectrum of classification are interested even in mild to moderate tracheas with valve regurgitation if it is associated with annular dilatation. Now, there is a development in the interventional or percutaneous repair of the tracheas with valve. That's why they have expanded the classification of the tracheas with valve regurgitation into massive and torrential. And for the interventional realm, they accept a reduction from torrential to massive and from massive to severe. Of course, this does not apply to surgery. In surgery, people do not accept annular dilatation with moderate tracheas with valve regurgitations. You can see here total different look at the tracheas with valve from interventional and surgical perspective. Before 2005, people are actually working on the tracheas with valve without having any objective criteria. They did not know the effect of the annular dilatation on the outcome of the tracheas with, what are the cutoffs. So the work on the tracheas with beyond that landmark paper by Jill Dravis from UK, people were totally lost. So, so this landmark paper has been the foundation of all the work that has come after, both interventional and surgical interventions. So the subject of that paper, it has shown that annular dilatation beyond 40 millimeters or 21 millimeter per meter square is associated with progression of the tracheas with valve regurgitation. So once the focus has become on the annular dilatation, even if there is no severe tracheas with valve regurgitation, imaging had to cope with that paper and improve the measurement of the annulus. And for us as surgeons, we have also to look at those who provide us reports on the tracheas with valve measurements. We have to see how they did it. Usually they measure the tracheas with annulus from transthoracic echo on a 4-chamber view. So you will see that if the 4-chamber view, the apex is formed by the LV, you will understand right away that the tracheas with annulus has been underestimated. So you will want the echocardiographer to focus a 4-chamber view, which shows the apex of the RV. And then maybe it is approximately correct measurement of the tracheas with valve annulus. So this is the view you want to look at when you are given a measurement of the tracheas with valve annulus, not the one on the left side of the screen. On transesophageal echo, you want to have measurement of the annulus as close as possible to the widest annular diameter. The widest annular diameter is the diameter from the anteroseptal commissure to the anteroposterior commissure. That is from the fixed point to the most dilated point of the tracheas with annulus. To remind you, the dilatable part of the tracheas with annulus is the annulus opposite to the anterior leaflet and the annulus opposite to the posterior leaflet. So that's the free wall of the RV, which distends. The annulus opposite to the septal leaflet does not distend. So you want to have a measurement of the annulus from the fixed point, which is the anteroseptal commissure, to the most dilatable part, which is the anteroposterior commissure. And that on transesophageal echo corresponds to a view that shows the coronary sinus. That way you have an approximate measurement of the true or nearly correct tracheas with annular diameter. you are looking for tricuspid annulus, of course, not when you have a severe tricuspid valve regurgitation like that. So in this case, it is obviously dilated and you already have severe tricuspid valve regurgitation, severe RV dilatation, and right atrial dilatation. So you don't go meticulous with the echocardiographer or your cardiologist regarding measurement of the annulus in such a case. You go when you have mild to moderate or even no TR, and the patient is going for mitral valve surgery. You want to decide whether to address that tricuspid or not, even if there is no severe tricuspid valve regurgitation. So you have to look into the appropriate views in which the tricuspid valve annulus was measured. Surgical indications for tricuspid valve surgery. We know that recommendations, class 1 means things should be done, and class 3 means should not be done. And in intermediate recommendations, class 2, A and B is something to be weighed. You notice here is just green, yellow, and oranges, and you don't have class 3. So unfortunately you have, or unfortunately you have only a couple of class 1 indications. So it's easy to know when to fix the tricuspid valve regurgitation. It's just when you have severe tricuspid valve regurgitation, symptomatic or asymptomatic, when the patient is going for left side heart surgery, valve surgery, mitral or aortic. And if you have severe symptomatic tricuspid valve regurgitation or severe tricuspid stenosis, is also class 1 to do tricuspid valve surgery. There is no class 3, so one would ask himself why in the United States there are 1.6 million who have significant tricuspid regurg, and they are not fixed surgically, while there is no class 3. It's just people do not know when not to do the surgery in terms of randomized controlled trials. But in practice, people know which patients do not benefit. And these are probably the 1.6 million who are roaming around looking for interventions, and the surgeons are turning down. Here is a flow diagram for tricuspid valve surgery. It's very clear and straightforward. At the time of need for left heart surgery, you look into the kind of tricuspid valve regurgitation. If it is severe primary TR and the patient is markedly symptomatic, you need to do tricuspid valve repair. But here is the statement that shows you it should be class 3 in this situation. You have a kind of tricuspid valve regurgitation, which is severe, and looking for absence of severe RV dysfunction, LV dysfunction, severe pulmonary hypertension. If this exists, conservative treatment. So they didn't want to say it is class 3, but they said conservative treatment. Actually, these are the cases that needs to be avoided. We'll elaborate more when we come further. So you decide that the patient needs tricuspid valve surgery. The surgical approach, of course, the tricuspid valve is very easily accessible. It can be accessed through a sternotomy or a right thoracotomy. It depends on the surgeon preference and institution preferences. Of course, when you are dealing with severe tricuspid pathology like endocarditis, you might require a lot of reconstruction. Sternotomy would be better. The surgery is done on cardiopulmonary bypass. You need to isolate the right atrium, meaning you should have bypass through inferior vena cava and superior vena cava cannulated, either centrally or peripherally. And if you cannulate both cavi, you need to isolate them. You don't want air to enter into them, so you snare them or balloon them. No matter what technique you use, you shouldn't allow air to enter into the cavi when they are cannulated. You have different settings for reoperation. When you are doing a redo tricuspid valve surgery, always think beforehand that your epicardial leads are tested and functioning well. Consider permanent epicardial leads when you are doing tricuspid valve replacement, and also consider the feasibility of having leadless pacemaker, which can be available, and it's helpful if you do tricuspid valve replacement and you don't want to do to place permanent epicardial leads. This is an example of access through right thoracotomy. So it is right there. Once you open the pericardium, you have the right atrium right in front of you. Of course, with such an aperture, you need to have peripheral cannulation of both SVC and IVC. Because surgery on the tricuspid valve is very risky, people have made some risk stratification models. This is one of them made by STS. And you can see here the warning signs. If the age is above 70, this makes 3 times higher risk. Patients on dialysis, patients who have severe chronic liver disease, and when you have severely symptomatic patients in NIHA class 4, and in patients in emergency surgery. One aspect of the tricuspid valve assessment, of course, is the clinical assessment. When you assess clinically the patient and there are signs of right side failure, ascites, and lower limb edema, obviously you are dealing with an advanced disease that needs a lot of workup, and you need to make sure that it is the tricuspid valve that's causing the problem, not other issues. We'll come later to know what are these issues. So what is the surgery for the tricuspid valve? It's mostly annuloplasty. So I would say 90% of the tricuspid valve surgery is annuloplasty. And the term annuloplasty is quite broad. Let's call it annular plication. Because in secondary TR, which is the most common type of pathology surgeons deals with, there is annular dilatation. So if the annulus is dilated, you need to cut it down. You need to cut the size of the annulus down for the leaflets to be able to co-opt and to have a competent valve. So what you do is to place annular suture within the annulus and to placate them. In the old days, they use it de vega, so it's just a plication of all the suture, bringing down the size of the annulus. Now, annuloplasty means taking wider bites on the annulus itself and then narrower bites on the annuloplasty ring or band. This way, you cut down the size of the annulus. By cutting down the size of the annulus, you fix the pathology, which is functional tricuspid valve regurgitation or annular dilatation. Other modes of fixing surgeries on the tricuspid valve include repair of ruptured core D or repair of perforated tricuspid leaflets, the same things that we do on the mitral valve. So how do you size the tricuspid ring? When you do annuloplasty means plication of the annulus and fixing that plication with a band or a ring. So these things go together. So plication and fixation of that plication with the ring. This is the most available, durable the surgery on the tricuspid valve. Sizing of the ring is basically you grab all the core D attached to the anterior and posterior leaflets of the tricuspid valve, stretch them posteriorly, and take the cider. They should correspond to the surface of the anterior and posterior leaflets, and that will be the size of the ring you need. Where to place the annuloplasty sutures? You place them from 6 o'clock to 9 o'clock or 10 o'clock. This way you spare the fixed part of the tricuspid valve and you avoid the conduction system. So, and this would be the final shape of annuloplasty suture. So this picture is basically what is the most commonly performed procedure in the tricuspid valve that should be mastered by every surgeon, and every trainee after finishing his training should know this procedure, how indications and how to do it. It is simple. It doesn't add much to the morbidity or mortality of any surgical procedure for cardiac surgery. One precautions is that when you do annuloplasty, there is always a risk of causing over annuloplasty or over reduction of the annulus, and this is very bad because better to leave TR than to have a tricuspid valve stenosis, because there is no medical treatment for tricuspid valve stenosis. Results of the tricuspid valve plasty or annuloplasty using different techniques. There have been different techniques used. Now it's only the semi-rigid or flexible ring that is more durable in terms of annuloplasty. The Vega, very rarely used, it has bad results. Tricuspid valve replacement is not a good procedure. It should be avoided as much as possible. Better to have moderate TR than to have a replacement. It's performed when there is failure of reconstructive technique. It carries a high mortality, high risk of heart blocks. It prevents insertion of transvenous pacemaker. Fortunately, there are now leadless pacemakers. The use of valves, mechanical versus bioprosthetic. Of course, there is a lot of stasis on the right side. You want to use a bioprosthesis, has a better result for tricuspid valve replacement. You should always have a plan for permanent pacemaker insertion. Consider leadless pacemaker if available in the center. And consider placement of permanent epicardial leads in some situation. Reoperative tricuspid valve surgery. This is this case or this scenario is very complicated. If you have a patient who had a previous surgery and present with severe TR, the decision should not be taken right away. If the patient is suffering, get him admitted to the hospital, form a multidisciplinary team, including the cardiologist, assess the left side first, because if you have a left side problem that is not addressed or persistent left side problem, you will fail to fix the tricuspid valve. Make sure the mitral valve is working well. The LV function is reasonable, no severe LV dysfunction. So basically, all left side heart problems should be ruled out. The second thing, in the patient who has congestive heart failure, ascites, lower limb edema, and a previous surgery, you have to rule out constrictive pericarditis as an etiology of what the patient is having. Make sure the liver function is restorable. So patient has deteriorating liver function or kidney function, admit him to the hospital, diurese him, make him dry, see how the liver does. If decongestion of the liver does not lead to improvement, it means the patient will not tolerate surgery. and also in these patients rule out an abdominal malignancy. So you need to have time to manage, see frequent visits, a lot of tests before subjecting the patient to tricuspid valve surgery, which carries a very high mortality, and the prognosis, nobody has proved that tricuspid valve surgery has any prognostic advantage. When not to operate on tricuspid valve, this is a difficult question because no guidelines have shown class 3 indication for tricuspid valve, means not to do. So if there is no class 3, means it's very difficult to put forward a case that this should not perform tricuspid valve, although in real life people turn down patients of tricuspid valve surgery. But if you have a patient with severe LV dysfunction, very hard to define, but let's say ejection fraction below 20, and severe RV dysfunction, again, very difficult to define, talk to the cardiologist, ask him how bad is the RV, TAPSE, a lot of measurements, no cutoff, but patients labeled as severe RV dysfunction, severe LV dysfunction, should not undergo cardiac surgery for a tricuspid valve. Patients with severe pulmonary hypertension, again, they will not benefit. They might be harmed by tricuspid valve surgery. There is no precise threshold for RV dysfunction. There is a lacking data, unfortunately, on this part of the tricuspid. So now we're discussing patients going for left heart surgery, and he has severe tricuspid valve regurgitation. We addressed that by guidelines. Patients going for mitral valve surgery has moderate tricuspid valve regurgitation and annular dilatation. We address the tricuspid valve. Some surgeons doing mitral valve surgery with mild tricuspid valve regurgitation and annular dilatation still do annuloplasty for the tricuspid valve regurgitation. So that's one side. Here I label this slide the annulus and reversibility conundrum. Here, Tyrone David challenged altogether the concept that was presented by Jill Davis and his group. He said that tricuspid annulus diameter does not predict the development of tricuspid valve regurgitation after mitral valve repair or mitral regurgitation due to degenerative disease. Toronto group do not believe that if you have mild to moderate or annular dilatation of the tricuspid valve will lead to subsequent tricuspid valve regurgitation at the, after performing mitral valve surgery. So what's the compromise? Who should we believe? The paper of Jill Davis, which all people follow now, or the Toronto and Tyrone David concept? Tyrone David has studied his patients, which were not as large as Jill Davis group. Jill Davis group have shown a study has been proven by subsequent studies, observational studies by other centers, and it is what the people are following now. So it depends. I think it puts the people in a comfort zone. So if you have a patient with mild tricuspid valve regurgitation and annular dilatation, and you are doing a degenerative mitral valve surgery, so you have the options either to fix the tricuspid valve or not to fix it. You can argue that Tyrone David data did not prove that I should fix it, and you will be okay. But remember that when you are doing mitral valve surgery, if you or concomitant tricuspid valve surgery, you are not adding to the mortality or morbidity of the patient, and there would be a lot of regret if the patient comes back with tricuspid valve regurgitation in the future. So here is another slide, whereby in a subset of patients of CTEPH, chronic thromboembolic pulmonary hypertension, these patients go for pulmonary thrombectomy. It's type 4 pulmonary hypertension patients. These patients, most of them, they have severe tricuspid valve regurgitation, most of them. And they have severe pulmonary hypertension. They undergo pulmonary thrombectomy, and the most expert center, San Diego, Jameson, did 1,500 cases, and he totally recommended against doing any tricuspid valve procedure in these patients. So these patients have severe TR, they have annular dilatation, and you still leave the tricuspid valve alone. So tricuspid annuloplasty was not performed on these patients, and it is totally okay according to Jameson. So this type of tricuspid valve regurgitation, it is functional tricuspid valve regurgitation, and I wouldn't say it should not be, but it is okay not to perform tricuspid annuloplasty concomitant with pulmonary thrombectomy. Some part of one of the causes of primary tricuspid valve regurgitation is carcinoid disease. It is a metastatic neuroendocrine tumor of the midgut. It does cause heart disease, carcinoid heart disease in 20%. Serotonin is the biomarker of that disease. It can cause TR or TS or pulmonary stenosis. It can affect the left side if there is a shunt. The surgery for these patients is performed for symptoms relief. Nobody has proven survival advantage. The use of mechanical versus biological valve, no data. People think that a biological valve can be attacked by the serotonins, and it can cause early degeneration, not proven. At the same time, if you put a mechanical valve, there is a high risk of thrombosis. I think it's a very rare disease. I would put a biological valve in case I have to do a carcinoid disease. Like thyroid disease, you can get thyroid crisis. Here you can get carcinoid crisis. And the treatment, if you get a patient with carcinoid disease going for tricuspid valve surgery or any cardiac surgery, you should have medical control with octreotide. Make sure that octreotide is available in your hospital, which is a somatostatin analog. In conclusions, tricuspid valve surgery, although it is simple, it's just annuloplasty for most of the cases. People should respect the anatomical relationship, the triangle of Cox. Placing snares should not be forgotten to avoid an airlock. Respect the aortic root. It's easy to forget. It's rare, but you can injure the aortic root. The first time primary surgery, when the risk is still low, is the best time to prevent a lethal late TR. So if you think whether you should do the tricuspid valve repair in concomitant with other surgery, better to err on the side of doing it than regret later, because we can have a lethal tricuspid valve regurgitation. So low threshold for tricuspid valve plasty in cases of elevated pulmonary artery pressure, in case of annular dilatation, and in case of atrial fibrillation also. Patients who require redo surgery, admit them, take enough time, monitor the patient, see the response of medical treatment, exclude other pathologies like constrictive pericarditis, abdominal malignancies, make sure the left side is okay. Yeah, thank you.
Thank you, Dr. Nadir. We are honored to have you with us, and thank you for spending this time and effort.
Thank you, Murtada.
Thank you, Dr. Nadir.
Thank you.
Thank you, Dr. Nadir. Abdulaziz Shamri from KFMC Riyadh. Dr. Nadir, my question for you, if you did the repair or replacement of the repair of for the tricuspid valve, when you will go back, or when you did you accept the mild to moderate TR, or you have to go again and address?
Yes. So what to expect from in terms of tricuspid valve regurgitation results? So fortunately, the tricuspid valve is a valve. The surgery on the tricuspid valve can be performed on a beating heart. So you can spend a lot of time trying to fix the tricuspid valve without adding to mortality and morbidity of the patient. As far as your question is concerned, whether to accept moderate, mild, of course, everybody accept mild. The question is moderate and more. Severe should not be acceptable, of course. It's hard for the patient who had a repair to leave the OR with severe tricuspid valve regurgitation. Moderate depends on the situation. If your concomitant surgery has been too long bypass time, and you think you might hurt the patient by spending more time on cardiopulmonary bypass, you can accept tricuspid valve, moderate tricuspid valve regurgitation if it were severe in the beginning, provided that you did not leave a primary problem like distorting the leaflets or injuring a chordae or something like that. If it's something easy to fix, then it should better be fixed. And if you think it's too high risk to continue the surgery, it's okay to accept the moderate tricuspid valve regurgitation.
Okay, thank you. Thank you so much.
Thank you, Dr. Nadir. Well, if you will allow, we can have a few minutes of break and start at 9:50.
Sure.
Okay. دكتور نذير.
السلام عليكم.
عليكم السلام.
السلام.
You want me to start the?
Yes, please.
Yes. Just to make sure the screen is obvious.
Screen is clear.
Okay. طيب. بسم الله الرحمن الرحيم. Back again for the course of surgical indications for infective endocarditis. Let's start with this case scenario. A 46-year-old female treated for several weeks as a case of documented MRSA infective endocarditis in another hospital. The lady was non-ambulatory because of advanced rheumatoid arthritis. She has bed sores, not in frank heart failure. Her CT brain shows showers without stroke, without neurological deficit. Her white cell count were within normal. She continues to take antibiotics, and she now has negative blood cultures. This is a parasternal long axis view of transthoracic echo showing vegetations of the mitral valve, anterior mitral valve leaflets, oscillating back and forth with the leaflets motion. There is an associated mitral valve regurgitation. It is graded as moderate mitral valve regurgitation. The oscillating mass measures more than 2 centimeters in diameter. The other valves were okay. So we hope to make decisions after this presentation about this patient. Overview. We'll go over the definitions related to infective endocarditis, its types, diagnosis, surgical indications, and principles of surgery on infective endocarditis. So what is infective endocarditis? So the term implies a disease of endocardial surface. It's quite broad. Of course, infection doesn't happen in the whole interior of the endocardium of the patient, but it basically involves the cardiac valves, native or prosthetic, and implanted devices. Nobody cares about other endocardial surfaces. It is called acute infective endocarditis when it happens in days up to 6 weeks. A month and a half or less is acute. Subacute from 6 weeks to 3 months. Chronic infective endocarditis, chronic endocarditis when it is more than 3 months. Another subtype of endocarditis called prosthetic valve endocarditis, PVE, is subclassified into early, less than 2 months, or late, beyond 2 months. Another subtype of endocarditis is called IVDA, intravenous drug abuse endocarditis. These are subclassified or they require specific mentioning because they are different, they're treated differently, basically. It's not rare. Infective endocarditis affects 15 cases per 100,000, and 1/3 of those require surgery. The risk factors for infective endocarditis include degenerative valve disease, rheumatic heart disease, prosthetic valves, indwelling catheters, implanted cardiac devices, diabetes and immunosuppression, and congenital heart defects. What is the pathogenesis of infective endocarditis? The organisms that cause infective endocarditis, they have high virulence, and that high virulence is related to their ability to form what is called a biofilm to protect themselves in the biological milieu. A biofilm is a biological material, slimy, from the polysaccharides of the extracellular matrix. It protects the cells, and some of the cells of the bacterial cells become persister cells, and there is what is called as quorum sensing in microbiology term, that denotes cells talk to each other by secreting certain substances, and this is genetically controlled procedure. So some of those bacteria that cause endocarditis and have these abilities to cause, to form a biofilm to protect themselves include Staph aureus. It's the most common form of infective endocarditis. Second most common is viridans streptococci, then has a group fungi and other bacteria can cause infective endocarditis. The diagnosis of infective endocarditis relies on what is called Jones criteria. It's basically you need two major, for a definite endocarditis, you need two major criteria, or one major and three minor, or five minor criteria. And possible endocarditis if you have one major and one minor, or three minor criteria. Most important is to have positive blood cultures, and for us surgeons, you need to have evidence of endocardial involvement in the form of vegetations or valve dysfunction, clearly valve perforation, and the echo criteria that we know about. The minor criteria are mostly related to medical workup. Predisposing cardiac valve problems, intravenous drug abuse, pyrexia, embolic phenomena, vasculitic phenomena, blood cultures, and suggestive echocardiographic findings. For surgeons, you need to see an image of heart affection. Of course, cultures, blood workup, they can all be there, but if you don't have clear findings on the imaging, there is nothing to work on as a surgeon. So imaging, interpretation of imaging is a cornerstone for surgical infective endocarditis, transthoracic echo, transesophageal, intracardiac echocardiography, multi-slice CT, MRI, PET scan, and cerebral angiography. So infective endocarditis is called, they call it infective endocarditis. That means there is a non-infective sort of endocarditis, means non-bacterial endocarditis. There are these entities that we need to know because we can confuse them with infective endocarditis. And the aim of management would be totally different. These include marantic or thrombotic endocarditis can convert into infective endocarditis. We need to look into that if the patient is presented with features of endocarditis and not obviously infected, and then you get bacteremia or blood cultures positive. You have to think of converting non-bacterial endocarditis or non-infective endocarditis. Liebman-Sachs, flat vegetation from both sides of the valve. You can have a rheumatic endocarditis. You can have a carcinoid endocarditis, and you can have a negative culture endocarditis related to previous antibiotic use, which is common, or endocarditis related to Hasig group of organisms. Why surgery? So we said that 1/3 of patients with infective endocarditis will require surgery. The surgery is performed because if the valve gets infected and becomes leaky and has disintegrated tissue, it will not be normal. It will not be treated medically. The tissues, disintegrated tissues will not regrow, and the valve will not become competent. Another issue of surgery is time of surgery. So there is a trade-off too early surgery is bad and too late surgery can be bad. Antimicrobials are very important in the initial management of infective endocarditis. They can clear the bacteremia. They thereby decrease sepsis and decrease recurrent infective endocarditis and prevent or halt destruction that may happen. Objective of surgery in infective endocarditis. Infective endocarditis is a lethal disease. It has nearly 50% mortality. The objective of surgery is elimination of infection and treatment of complications of endocarditis. What are the indications? So patient has infective endocarditis with heart failure. There is a valve dysfunction or intracardiac fistula causing pulmonary edema or cardiogenic shock. These should go for surgery. Or if there is persistent infection, enlarging vegetation, persistent bacteremia, despite appropriate antibiotic therapy. Complications of infection include local uncontrolled infection resulting in abscess, heart block, or penetrating lesion, especially in aortic root. Prevention of embolism, if you have mobile vegetations like the one we saw in the case, when involving anterior mitral leaflet in the setting of previous embolic episode. These are the indications of surgery. Algorithm for decision making. This is very helpful actually. If you have possible or definite endocarditis and major ischemic or intracranial hemorrhage, if that's a situation, there is a stroke recent, then the surgery should be delayed because early intervention in this case can lead to bad consequences. The surgery is delayed for a term of 4 weeks, can be less by 1 week or more by 1 or 2 weeks. If there is no stroke, presence of any one of the following, like in the previous slide, valve dysfunction causing heart failure, like new severe MR, new severe aortic regurgitation, new severe TR, causing heart failure, this should go for early surgical intervention. Or if you have resistant organisms, including Staph aureus or fungal endocarditis, heart block or abscesses in the aortic root, persistent infection, relapsing prosthetic valve endocarditis, these are indications for early surgical intervention. Early means within a week or so, surgery has to be done. If you don't have the previous criteria, if you have large mobile vegetation or recurrent emboli, persistent vegetation, despite appropriate antibiotic therapy, consider early surgical intervention, and this is a class 2 indication. If none of the above is existing, the treatment is just antibiotic therapy. So the American Association of Thoracic Surgeons has class 1 and class 2 indications for interventions. Basically a summary of what has been mentioned earlier: heart failure resulting from valve destruction, certain organisms, MRSA, fungi, and highly resistant organisms, advanced invasive pathology, fistulation or heart blocks, unresponsive sepsis, recurrent infections, and infective prosthetic valves are class 1 indications for early interventions. Timing of surgery has always been a problem, but if there is no stroke, the early, the better. Myocardic aneurysm is an association with infective endocarditis. Always in the history of patients of infective endocarditis, one should ask to try to elicit a history of lapse of consciousness, headache, neurological deficit, memory deficit, total neurological assessment. And if patient condition allows, investigations by cerebral angiography should be performed. If it is there, the mortality is increased 30% if it is unruptured, and 80% if it is ruptured. So this graph shows that early intervention in the setting of stroke has bad outcome. So in the y-axis, you have percentage of survival, and the x-axis, the days after the surgery. So the hospital survival is better if the surgical intervention is delayed a little bit more than 2 weeks after a stroke. Here is what is important for surgery, principles of reconstructive surgery in effective endocarditis. If the patient is going for infective endocarditis surgery, thinking should be planned beforehand. Have a good myocardial protection plan, especially if it's a prosthetic valve endocarditis. So if the patient has a prosthetic valve endocarditis for aortic prosthesis, for example, you might not be able to deliver cardioplegia easily through the ostia, because the prosthesis usually would be covering the ostia. Know the principles of adequate debridement. Debridement means excision of dead tissue. When you are dealing with dead or live, the decision is not easy. You don't have much time to know which tissues is alive, which tissue is dead. You have to quickly do something. The obvious dead tissue can easily be removed, easily debrided by sucker. But the viable versus non-viable tissues, the best test to do is if the tissues are holding the needle and you pull on the tissues, if they are holding the suture, it means better to be left alone. Because overzealous debridement can lead to bad consequences. And again, leaving a dead tissue behind will not achieve the objective of debridement. And when you go into a case of effective endocarditis, don't go with a single plan for reconstruction, because you might need to do less in the case, or you might need to do more. So have your mindset ready for any scenario intraoperative. Autologous pericardium is your friend. It's the best tissue to use. It resists infection and easy to suture. Technical aspects that need to know, surgeon needs to know the anatomy. Of course, the surgeon has to have a broad spectrum of the anatomy of the heart. The lesions that start from the left side should be addressed from the left side. What does that mean? If you have a fistula, for example, from aortic root into any other chamber, the best way is to address it from the aortic side, or from high pressure side rather than the low pressure side. Otherwise, it would recur. If you are dealing with mitral and tricuspid valve endocarditis, when you're doing the reconstruction, make sure you restore the endocardial to endocardial continuity. Otherwise, you will not have a watertight seal, and you can end up with bad bleeding and maybe mortality. And in case of aortic root endocarditis, try to restore endocardial to endothelial continuity. Make sure your LV is connected to the aorta. Otherwise, again, you can have pseudoaneurysm formation or immediate bleeding postoperatively. The suture line should be watertight. Suture should be placed on healthy tissues. So if the tissues do not hold well, after placing the suture, try to pull on the sutures a little bit, make sure they don't break through. If they break through, means you are suturing on dead tissue already. If there is an abscess cavity, try to drain it to the pericardial sac and patch it towards inside the heart. So it should be open through the pericardium. Always consider pacemaking setup whether by permanent epicardial leads or temporal leads. This is a case of 32 years old female. She had a previous mitral valve replacement. She came cachectic, had staph endocarditis of the prosthetic valve. Echo has showed severe mitral paravalvular leak, severe aortic stenosis, and total disruption of the aortomitral continuity. Aortomitral disconnection. Aortomitral disconnection, I highlighted this because it is one of the things that the surgeon should know how to manage aortomitral disconnection, because it's a major surgery and very painful. This is a parasternal view of the case. You can appreciate here at the top, after the RV, you have the aortic valve, and then you have a cavity that extends behind the aortic valve, and then you have the mitral prosthesis, totally disrupted aortic and mitral valve with a kind of pseudoaneurysms or extension of the LV between the two valves. So this case is very demanding, and it requires operations called, most of the people do a commando operation. I thought I should share with you what we did for this case. Here you have the aortic valve, the circle, the smaller circle, and then the mitral valve, and then the elliptical shape here is the cavity in between. So what we did, we excised both valves and taken the sutures for the aortic valve from the mitral annulus through that cavity to the aortic annulus. And we did the opposite for some of the sutures of the mitral valve were taken from the aortic annulus through the mitral annulus to the mitral prosthesis. This way, we obliterated the cavity and restored the aortomitral continuity. And this is the case 3 years later. Totally connected mitral and aortic roots. This is a case of non-coronary sinus replacement in a case of Procella endocarditis. Procella is a notorious organism that causes endocarditis. 47 male police officer had fever and congestive heart failure, proven to have Procella infective endocarditis with a pseudoaneurysm with rupture of the sinus, non-coronary sinus on one side, and you can see this triangular shape pseudoaneurysm here. I'm sharing these cases because the mindset has to be prepared for any scenario that you go in, should be ready to perform. So this case required, in addition to aortic valve replacement, required one sinus replacement because the sinus itself was ruptured. So we had to replace the sinus in addition to aortic valve replacement. Types of prosthesis, homograft, no difference. We know that from late literature that there is no difference between using biological valve, homograft, or a mechanical prosthesis. So let's go back to the patient we discussed earlier. She was a young lady, referred for after several weeks of documented MRSA infective endocarditis, advanced rheumatoid arthritis, rendering her non-ambulatory. She had bed sores, CT brain showers, and non-neurological deficit. So before we discuss this case, any questions in the presentation?
Thank you.
Thank you. Okay. So no questions. So any thoughts of what we should do for this lady, young lady with mitral valve endocarditis? Anybody would like to comment on what we should do?
Uh, I will.
Yes, please, Murtada.
So this patient has been already diagnosed with infective endocarditis and started antibiotic therapy. Currently, the patient does not have, according to this um, information here, the patient does not have any heart failure symptoms, right?
Correct.
Okay, so in terms of indication for surgery now, she has an indication for surgery because she has virulent organism, which is the MRSA, as a class 1 indication. And she also has showering, which is embolization, which is a class 2 A if it is recurrent despite antibiotics. Here it does not say that there is recurrent embolization. So this patient needs to go for surgery for the mitral valve, and the timing of surgery will be early, as soon as possible. Even in the presence of showering without clinical evidence of stroke. So for this patient, I will discuss the case with the heart team, and I will include the neurology and neurosurgery for their opinion regarding the risk of recurrent stroke during surgery. And I will do all my investigation and, of course, examining the patient, taking history and everything, and then I will prepare her for us.
That sounds good, Murtada. It's good systemic thinking. I like it. Anybody else has any opinion?
Okay, Doctor. I agree with Murtada. She's a class 1 indication for surgical intervention, early surgical intervention, because she had MRSA and she had embolic events. But my concern regarding the mobility of the patient and other source of infection, like a bed source. I'm not sure the bed source is infected or no, and we need to investigate about this. If there is any source of infection, I think it will interfere with the timing of intervention.
Absolutely. I agree with your reservations. And actually, we have taken the same reservations on this patient. Anybody else would like to share his opinion? So, yeah, so this is the way we thought about this patient, looking at the echo and the vegetations and the leaky valve. Looking at these images alone and the history of MRSA, we thought the patient should go for surgery. Then when we came to evaluate the patient bedside, he was totally bedridden, bed sores. We looked back into the cultures. She was negative for subsequent cultures. Her mitral valve regurgitation was moderate. So that takes her off class 1 indications for surgery. She becomes class 2, A or B, because of the presence of vegetations and previous showering without neurological phenomena. So we weighed the benefits versus risk, and we actually turned that patient down and followed her. She spent some time in the hospital, but eventually she was discharged home on antibiotics. But so this is the way we think about cases, put things together. Not always class 1 should go for surgery. You can have class 1 indication in terms of valve lesions, destroyed valve, severe heart failure patient with pulmonary edema because of acute severe mitral regurgitation or acute severe aortic regurgitation, and then the patient has a bleed in the brain, let's say. So that's class 1 indication for surgery in terms of cardiac imaging. But again, he has a reason not to take him right away for surgery. They say if you have a stroke, if it's symbolic, you wait for 4 weeks or so. If it is bleed, you wait for 4 weeks or 6 weeks. But how much stroke is the question? How much bleed in the brain? If the bleeding in the brain is huge, you might not take the patient at all to the OR because he has, let's say, bled in quarter hemisphere of his brain or half hemisphere. Or if the stroke is so massive that is involving almost a hemisphere of his brain, again, these patients, although from cardiac point of view, they are class 1, you still refrain from taking them to the operating room. If you have a reasonable amount of brain bleed and no much neurological sequelae, then you go with the criteria of taking the patient within 4 to 6 weeks to the theater. Any thoughts or discussion points or questions?
Yes, please. So this patient, she has an indication for surgery, but for the timing, in the guidelines, they said it's a class 2A to take the patient as urgent or emergent if there is an imminent risk of embolization. So when you took the decision to delay this patient, we are risking a major stroke if we are waiting, and we need to balance that decision with the risk of recurrent infection because of the presence of bed sore. So if we go and evaluate the patient clinically and we think that the patient will tolerate surgery, she is fit for OR, would you take the patient for just to decrease the risk of recurrent major stroke, even if there is a risk of recurrent infection because of the bed sore? If she is fit for surgery, would you take her?
Absolutely. So if the bed sore is not nasty, not deep, not growing organisms, I would take her for, we would have taken her for surgery. But bed sore, if it is deep, nasty looking, growing organisms, so the objective of eradication of infection is a problem. And from the start, to have a native valve endocarditis, when you have a spot elsewhere that you cannot clean, then you know that you will not be winning. So, because the pathology here is not the heart, and the source of infection is not the heart. The heart is secondarily affected. It is affected because the patient is immunocompromised, had a source of infection that you cannot control. Then he got endocarditis. So the disease here is the bed sore or whatever septic process ongoing in the body that's causing the problem of the patient. So I think bed sores or a source of infection elsewhere should not be taken lightly in terms of decision making, and not to be overwhelmed by the echo images people can give to you.
But Dr. Nadir, in the guidelines, they state clearly that the presence of infection is not a factor not to take the patient for surgery if there is a class 1 indication. So if we can take the patient for surgery with an active infection in the heart, why not taking the patient if there is an active infection outside the heart, if there is a class 1 indication?
Yeah, so the distinction here is very clear. If the heart, if there is an infection in the heart, and the heart is the source of infection that's showering to the body, then of course you should take the patient for surgery.
To control the source of infection.
If the heart is the source of infection, But if you have a major infection elsewhere, and because of immunocompromise, the infection went into the heart, and the other source you cannot deal with, like you know how bed sores can be, then you know the protoplasm of this patient is basically bad, infected elsewhere, immunocompromised, not ambulatory. It makes the risk profile, the whole risk profile, bad. So if you do cardiac surgery, you will just cause more disability to this patient, another incision, another infection, and so forth. But if you have a patient who had, let's say, had dental issues unnoticed, then develop endocarditis, that endocarditis showered to his body, then if you address the heart problem, then you make the patient better.
Dr. Nazir, can I have a comment?
Please.
I'm Ayman Ghunim from Al Musa Specialist Hospital. In this patient, the secret here is the word hard to decontaminate. I mean, if even the patient is ambulatory, not bedridden, but we have an infection, and if we can decontaminate, it's easy to solve it. We will solve and then we'll do the surgery. But if it is hard to do decontaminate, so no issue to do the surgery here. That's also my opinion. Thank you.
Absolutely, totally agree. Totally agree.
Thank you.
Thank you very much.
Thank you, Dr. Nadir.
Thank you very much indeed. Are we done?
No more question.
Thank you very much. أتمنى لكم التوفيق إن شاء الله بإذن الله.
Thank you, Dr. for your time. And hopefully we'll see you inshallah.
Inshallah. Thank you.
So I will check with Dr. Salih if he's around to start, or otherwise we'll start at 11.
Sure. Thank you, Roy.
Assalamu alaikum. So Dr. Saleh will join us now to start his lectures.
السلام عليكم.
عليكم السلام ورحمة الله.
عليكم السلام ورحمة الله.
السلام ورحمة الله. ما أدري إذا تشوفون السكرين ولا لا.
شايفين أنا.
والصورة واضحة؟
نعم.
تحبون نبدأ؟
اوكي.
أول شيء بسم الله الرحمن الرحيم. أنا حاب أعتذر عن الديلي إنه المفروض كنا يوم الخميس بس for something outside of my hands للأسف we could not come يوم الخميس. ECG teaching is a bit difficult. Everyone has different things to learn from the ECGs. I think it goes very well if it is more interactive. So the more interaction that we have, the better. إنه في الزوم شوية صعب الinteraction. What I'm going to do is I'm going to open the chat section and feel free to ask questions on the chat or answer the questions that I ask on the chat. But essentially, the first thing or the first concept that you need to learn about ECGs is that the first beat is the same across the ECG. Can you see the pointer? Can you see my pointer?
Yes.
So concept number one is this beat is exactly this beat, is exactly this beat, is exactly this beat. And this will become very important when you want to change or when you want to compare waveforms. So this is a P, this is a QRS, and this is a T. This is very obvious. As the patient becomes tachycardiac, as the quality of the ECG degrades, sometimes you look at the waveform and you really don't know, is this a P, is this a QRS, is this a T? So what you want to do is immediately go up and down the ECG. So whatever corresponds على هذا الأفق is the same beat. So this is a P, this is a P, this is a P, and so on. So if you're not sure what this waveform is, you go up and down the ECG. This is clearly a T wave, therefore it's a T wave. I think most of the time when you're struggling to read the ECG, you're really not struggling to read the ECG. You are really struggling to identify what is this waveform. Is this a P, a QRS, or a T, or something else? Who is this?
Thanks, Salman.
Sure. الويكند اليوم الوطني, you should know this very easily. So you see, when you saw King Salman, you didn't apply any criteria. It was just immediate pattern recognition. Same goes for all of these photos. You see them and then you either know them or you don't. This is the same for ECGs. So the only way to be excellent at ECG readings is to develop this habit of pattern recognition, where you just see an ECG and know it very, very well. You can use any criteria you want. All are good, all are equal. Nothing is really better than the other. They're just different styles. I'm going to skip the part where the basic science part, but essentially, this is the only concept that I want you to kind of understand, is that you want to know where the lead is sitting. So if lead one, for instance, sits on the left arm, and if the current is going towards lead one, the lead will be positive. And if it's going away from lead one, the lead will be negative. So lead one sits here, and this current or this vector of electricity is going away, therefore it appears negative. This is a very important concept that I think you guys should have. Those are interchangeable. Each machine has a default setup, but it's okay if you forget them. You can Google them. It's really not a big deal whatsoever. I'm going to talk about access in a bit. Are you guys comfortable measuring the rate? So the way the machine does it is by measuring the R to R interval, and this will tell you the rate. I think the better way of doing it visually is to find a QRS that is on the thick line and then go forward or backward. And if the next QRS is here, the rate is 300. If it's here, it's 150. If it's here, it's 100, 75, 60, 50. So this is between 60 and 75. So it's more than 60, it's less than 75, so I'd call it 65. Also, as you get more familiar with doing this, or as you do it more often, then you will see an ECG and you'll say, oh, this is tachycardiac, or this is bradycardiac. And that's what really is important clinically. There's another way by count. If the rate is irregular, or if the rhythm is irregular, we just count them and multiply by 6. All right, I'm gonna skip that. I feel like you probably guys would know it. So another really important concept is intervals in the ECG. So if you look at this, you need to train your eye to kind of pick up something. Something looks different here. And that thing is this QRS. Why is that? If you only look at the peak of the QRSs, so if you only look at this R to R interval, it's different than this R to R interval. Then we're back to the same intervals. فهذه مساوية لهذه مساوية لهذه مساوية لهذه. But this one is shorter. And the reason that this is shorter came earlier than anticipated, and it's preceded by a P wave. Therefore, we call it premature atrial contraction or a premature atrial beat. Same thing for PVCs. They come in, they're wide, but they throw the rhythm off. So this is different than this. PAC, PVC, different morphology PVC because it's coming from a different focus in the ventricle. Axis, are you comfortable calculating the axis? We'll practice on some of the ECGs, but I like to say from 0 to -90 is leftward axis. Some of the textbooks say from -30 to -90 is left axis, and this, they call it leftward. So this area يعني متنازع عليها. But you can call this left, call this segment normal, call this right, and this call it superior axis. There's really no need to memorize this. It's better to apply it on the ECG. So here, lead 1 is positive. If you look at AVF, it has a positive component and a negative component, but it is predominantly positive. When we say positive, we mean it's going up. So this is going up predominantly, and 1 is going up. So if 1 and AVF are both going up, that is a sign that everything is okay. So 1 is telling you it's okay, AVF is giving you thumbs up, so okay. So this is normal axis. So 1 up, AVF up, everything, you got 2 thumbs up, okay, okay, this is normal axis. If 1 is going down and AVF is going up, they are reaching each other, therefore this is right axis deviation. So 1 going down, AVF going up, they are reaching each other, right axis deviation. If 1 is up, AVF is down, they are leaving each other, that is left axis deviation. Does that make sense? The P wave is really helpful for right atrial abnormalities. So this P wave is more than 1/3 of the length of the QRS. Therefore, this signifies right atrial enlargement. And if you look at V1, this is only lead 2. If you look at V1, V1 should have 2 components: an initial activation, that is for the right atrial activation, and then a secondary activation or a late activation that is for the left atrium, because the right activation happens before the left, as we know, because the SA node is on the right side of the heart, or it's in the right atrium. So normally, if both atria are the same size, this should go up by, let's say, 1 or 2 millimeter, and then comes down by 1 or 2 millimeter. So it should be equal. If there is right atrial enlargement, the upward deflection or the positive deflection of the P wave will be bigger. So الأكبر سوف يسحب ال P wave إلى جهته. Here we can see that the upward deflection is more than the negative deflection. Therefore, it is right atrial enlargement. There are some classic P waves like this one. This is P mitral, or left, which signifies left atrial enlargement. It's a bifid P wave in lead 2, and in V1 it has more negative components. We've been through P pulmonale and we've covered P mitral. Now we'll talk about ventricular hypertrophy. So a lot of people look at the RV, a lot of people kind of miss RVH on ECG, but essentially in V1, you have an R taller than an S, which means that the positive component is more than the negative component. So normally in V1, V1 should go down, so it should be a negative waveform. But in RVH, definitely more positive component. The other thing that you have to have with RVH is right axis deviation. So essentially, when you see right axis deviation and an R that is taller than the S, or a positive deflection in V1, you should call that RVH. In LVH, we'll go over the criteria in LVH in a bit. There are a bunch of criteria. The easiest, I would say, is this one, which is you go to V5 or V6 and you take the R wave plus the S wave in V1 or V2, and it's more than 35 millimeter. Let's practice with this one. So with this ECG, it looks like there is LVH. A, because you have left axis deviation. B, you have tall waveforms. To confirm this or to apply criteria, we go to V1, نحسب من هنا all the way down, plus V5 all the way up. So if you add this, this is 5, 10, 15, 20, 25, let's say 25. Then 30, 35 plus. So as long as, once you exceed 35, you're all set. This is LVH. There is another criteria, which is the length or the how tall the R wave in AVL. So if the R wave in AVL is 12 and above, that is diagnostic of LVH. So I think the most helpful ones are this one and this one, those criteria. A very important thing is visually, when you see an ECG, it just looks like LVH because the amplitude of the ECG is too big. And you also always need to check the calibration and make sure it's calibrated at 10. So this box right here tells you in each 1 millivolt corresponds to 1 millimeter on the ECG. Do you guys see these ECG ST changes? So this is related to LVH. This is very typical. It's called strain pattern. So it is down-sloping ST segment depression with T wave inversion, and this is diagnostic of LVH. Here's another example. You have sinus rhythm, left axis deviation, and in all the leads, كل واحد داخل على الثاني. This is kind of your clue that it is that there is LVH. And if you apply the criteria, in AVL, it's more than 12 or 12 and above. And V1 plus V6 is definitely more than 35. Any question on this? Here's an example of RVH. So we have sinus rhythm. The axis here is right axis deviation because lead 1 is going down and AVF is going up. So they're reaching each other. The RS ratio is greater than 50%. What does that mean? It means that in V1, it's predominantly a positive component. V1 is essentially going up as opposed to V1 here, which is going down. All right. We've covered atrial enlargement, RVH, and LVH, and we'll cover now tachyarrhythmias. So tachyarrhythmias are really important. You will see them overnight. You will see them post-op. So it's really important to be comfortable with them. Flutter and fibrillation are very common. They kind of change outcomes. They prolong hospital stay. They predispose patients to strokes. They really change management because people with fib flutter should undergo certain evaluation, should be anticoagulated for stroke prevention. So it's really, I would say, flutter, AFib is a basic competency. So as a cardiac surgeon, I think you must be able to diagnose fibrillation. If you see someone in the clinic and you do an ECG, you should, and it shows flutter or fibrillation, you should be able to pick that up. Sorry about that. One sec. All right, another problem is SVT. So SVT is essentially supraventricular tachycardia. It's predominantly AV-NRT. And I think as cardiac surgeons, really the mode of the pathophysiology of the SVT is really not a big deal or not important for you. But I think you should be familiar with how it looks. So if you focus on the first half of the ECG right here, and if I ask you what is the rhythm here, you should be able to immediately say that this is not sinus rhythm, right? Because lead 2 should have a P wave if it's sinus rhythm, and this is clearly not sinus. So when you see this and I ask you what is the rhythm, your answer should be this is not sinus. So if it's not sinus, how do we define this rhythm or how do we describe it? And the best way to describe this is you say narrow complex tachycardia. So this is narrow complex tachycardia. We said narrow complex because narrow complex tachycardia because the rhythm is, the rate is fast. So there's clearly tachycardia and the QRSs are narrow. So when you see fast rhythm or fast rate with narrow QRS, you refer to that as narrow complex tachycardia. And why is it important?
Dr. Saleh, I'm not
Yes.
sure whether it's me only. I don't see the slides. Is it only me, guys?
No, we don't see it. I thought it was a connection problem.
Well, I can see from my side. I'm not sure.
Even
can
me,
see
I
the
can't see.
Do you see it now?
Yeah, I can see the slide.
I'll tell you what, maybe if you're logged on your phone, maybe the screen is zoomed in too much. So maybe try to swipe the screen, like take it to the left or to the right, or try to flip your phone so that it's in portrait.
Yeah.
If you focus on the first half of the ECG, it's like I said, it's narrow complex tachycardia, so it's fast and it is narrow QRSs. Why is it important to identify narrow complex tachycardia versus wide complex tachycardia? It's because of differential diagnosis. So when you have a narrow complex tachycardia, that is essentially sinus tachycardia, SVT, or fib flutter. That's pretty much the differential diagnosis for narrow complex tachycardia. While for wide complex tachycardia, the differential diagnosis is VT, VT, VT. So any wide complex tachycardia you see, you should assume that it's VT. Another possibility is SVT with aberrancy. What does that mean, SVT with aberrancy? It means something coming from above with a left or a right bundle branch block. Sorry, you have a question? So, for example, a patient with right bundle branch block, if they go fast, if they develop sinus tachycardia, they will still maintain that right bundle branch block, but now it will appear as wide complex tachycardia. Here, the patient was given adenosine, the arrhythmia terminates, and then we have a P wave that is upright. This is sinus beat, sinus, then an inverted P wave. The SVT is trying to initiate again, but it cannot. And then we're back to sinus rhythm. So guys, in the chat section, or you can open the microphone, what do you think this is? Waiting for your answers.
Okay, so this looks like SVT because there is a narrow complex tachycardia. There is, I think I can appreciate.
I think you said it. Instead of saying SVT, it would actually be better to call it what you just called it, which is narrow complex tachycardia. So narrow complex tachycardia, it's better to train your brain and your synapses and to just say that. Why? Because it's so easy. It is just easier to say narrow complex tachycardia. And yes, the differential diagnosis is SVT, and this is most likely an SVT, and you are correct. It is an SVT. Any questions on this?
No.
Perfect. What do you guys think of this? In the chat section, the way to refer to this is narrow complex tachycardia, which is NCT. Narrow complex tachycardia, NCT is a standard abbreviation, at least in cardiology, for narrow complex tachycardia, versus WCT, which is wide complex tachycardia. I'm giving you these acronyms because I expect participation in the chat section. So when you see this, I expect lots of people to say NCT. So what do we see? What do we have here?
Sinus tachycardia, I think.
Yes. So you should again say narrow complex tachycardia, and the diagnosis is sinus tachycardia. So sinus tachycardia, SVT, AFib flutter are clinical diagnoses, which is what we want to get to. Narrow complex tachycardia, wide complex tachycardia are descriptive terms for the ECG. This, I would call it a narrow because the QRSs are still narrow. Maybe lead 2 looks a little bit chubby, but it's not greater than 3 small squares. What do you guys think here? Those are the easy questions ترى لسه الإيسيجيات الصعبة جاية. Yes. Again, it's much better to be descriptive. So instead of jumping into the diagnosis, it's much better to just call this narrow complex tachycardia. I know you probably say, oh, that's too easy, but this is the right way of reading the ECG. So you just call this narrow complex tachycardia. And in the diagnosis, you are correct. This is sinus tachycardia. What do you guys think of the ST segments here?
A little bit depressed.
Yes, you're correct. In which leads?
Lead 2.
Yes.
Yeah, and lead 3 as well.
Yes. How about ABF? What do you think of ABF? Do you think it's depressed?
Yes.
Yeah. V3. V3 right here.
Yes.
V5, V6 are all depressed, right? So this is down, this is down, this is down. So this is diffuse ST segment depression with ST elevation in AVR, and that signifies left main disease or 3 vessel disease. This is large myocardial jeopardy, or this is large myocardium that is ischemic. So it's either 3 proximal vessels that are ischemic or significant left main disease.
What about pericarditis? I know that in pericarditis you can have a diffuse ST segment elevation. What
Correct.
about
So You don't have ST segment depression, you have ST segment elevation. So in pericarditis, you have diffuse ST segment elevation, but never depression. So these, this signifies ischemia.
Thank you.
So what do we have here?
I think wide QRS complex.
Correct, wide complex tachycardia. Wide complex tachycardia. I thought you guys are going to say VT. VT would be the incorrect way to read the ECG. So this is, yes, you are correct. The clinical diagnosis here is VT, but it's much better to also, again, train yourself to say is wide complex tachycardia. Most likely it's ventricular tachycardia. All right, skip this. We'll skip this. So just, I'm sure you guys know this, but VT starts like this, becomes wider, becomes less organized, degenerates into VF, and becomes asystolic in matters of like minutes. That's why electricity, so cardioversion, defibrillation, if given early on, will, essentially save lives. So we'll talk about AV conduction abnormalities. So we have first, second, and third degree AV blocks.
You are muted, Dr. Saleh.
Sorry about that. So first degree AV block is not actually a block because all the P's are conducted, but the PR interval is greater than 200 milliseconds. So what we're seeing here is from the onset of the P to the first positive or negative deflection, more than 200 milliseconds. And the PR interval, you could actually cheat because the ECG calculates it very, very well. So if you look at the PR interval as measured by the machine and it's greater than 200 milliseconds, that's essentially first degree AV block. If you have any P that did not conduct, khalas, first degree is out, it's greater than first degree. First degree is benign, it's really not associated with morbidities, it just signifies that there is AV or there is conduction system abnormalities. Second degree AV block is two types. So type 1 is Winkelbach, type 2 is Mobitz type 2 is a fixed interval. So Winkelbach or Mobitz type 1 is characterized by prolongation of PR interval followed by a drop. So this PR interval becomes longer than drops. PR interval becomes longer than drops. The easiest way to pick up Mobitz type 1 or Winkelbach is that there's group beating. So you can see here 2 beats, 2 beats, 2 beats, 2 beats. So they come in groups. The other thing is, if you look at the pause, so the dropped P, and compare the PR interval after and before. So visually, if you go back and forth between this one and this one, you will clearly spot the difference because this is going to be the shortest PR and this is going to be the longest PR, particularly when it's a really like 3 or 4 or 5 beats that is prolonging. While 2-to-1 is, while Mobitz type 2 is infranodal and is more severe. So Mobitz type 2 signifies infranodal or infrahisian disease, and it is more concerning and it requires a pacemaker most of the time. So here, if you look at the PR interval, it's not prolonging, and this is a Mobitz type 2 AV block. We would say this is 3-to-2. So 1, 2, 3 Ps for 2 QRSs. What do you guys think of this? So this is a V-paced, I'm sorry, this is a V-paced ECG. So we can see spikes. The spikes are generating QRSs, sorry about that. we can see spikes, and the spikes are followed by QRSs. So we can say that those are this is a ventricular pacemaker. This pacemaker is in the ventricle. All right. So what is the rhythm here? Okay. If you look at lead 2, what is this waveform? It's a P wave, and it's upright in lead 2. Therefore, we would say this is sinus rhythm, right? If you're not sure what this is or this is, again, we go back to the first initial rule, which is go up and down the ECG. So in here, if you go up, it corresponds to the QRS. So this is definitely the QRS, and this corresponds to the P. So that's definitely a P wave. There is also something else in the ECG.
I'm not sure. There is, I think there is no relation between the P and QRS.
Sure. So the first thing to say is that there is AV block, right? So
Yeah.
the first step is identify the abnormality. So there is AV block. You are correct. There is left bundle branch block as well. But if you follow the P's, this P gave us a QRS. This P gave us a QRS. This P failed to give us a QRS. If you look at lead 3, P, QRS, P, QRS, P, nothing. So this P should make us say that there is AV block. Then it's our task to say, okay, is it first, second, or third? So first is out because this P failed to conduct. So one P wave that doesn't conduct means first degree is out. It's not third because this gave us this and this gave us this.
Mobitz type 2, I think.
Exactly. So we're in the second degree. Second degree have two types, Mobitz type 1 and Mobitz type 2. Since the PR interval is not prolonging, it's fixed, this would be Mobitz type 2. Another clue that it's also Mobitz type 2 is the presence of left bundle. So left bundle branch block signifies that there is conduction disease, or there is an abnormality in the infranodal or in the conduction system. So here we have a left bundle branch block, which that tells me that this patient has an unhealthy conduction system. Makes sense? This is essentially an indication for pacemaker, which is second degree Mobitz type 2, not the left bundle. The left bundle favors Mobitz type 2 as opposed to Mobitz type 1. What's the rhythm here? We have this waveform. What do you guys think of this waveform?
P wave.
P wave. Therefore, the rhythm is sinus. So you have P wave upright in lead 2, sinus rhythm. All right. Anything else funny going on?
Getting prolonged each.
Yeah. So the PR, the P's and the QRSs, the relationship between the P's and the QRSs is not normal, right? So what the way to verbalize this, or the way to call this on the ECG, we say there is AV block. And then once you say there is AV block, the next question is first, second, or third degree. So I'm still waiting for more votes on the degree. We have first, we have third, we have second. All right. The majority is going for second. All right, this is third degree AV block. The reason is that it's third is that there is actually in the QRS. So if you say that this P gave us the QRS, how about this P? This P failed to give us anything. And this one is shorter. So we really have no conditions that shorten the PR interval in the next conducted beat. And so on. So this did not give us this. And here there is a hidden P wave that gave us nothing here. So there is AV dissociation. What that means is that the P's are happening, the QRSs are happening, but there is no relationship. Another clue that this third degree AV block is that in third degree AV block, the QRSs are usually regular. So if you look at the R to R interval here, it's fixed, it's irregular. So this is a regular narrow escape. All right, we'll go over right and left bundle. I think right and left bundles are also important to know. Let me find you a good example of right and left bundle. So here, this is a typical right bundle look, right? I really guys want you to know this, which is the R. If you look at V1, if you look at the pattern of QRS in V1, it has an R and then a deep S and then an R, like rabbit ears. This is a typical right bundle morphology. Then if you look at V6, so this is the first lead that you should look at, which is V1. And if you look at V6, usually it has a narrow upward component and then a deep S wave, deep wide S wave. So initially it looks narrow, then it's wide. The same in lead one. So lead one looks initially narrow and then wide S wave. Show you a left bundle just for comparison. This is what a left bundle looks like. So in V1, it has a deep negative component, and there is no RSR pattern. So there is no positive component. And if you look at V6, there is no negative component, and it's mainly a wide QRS that is notched in either lead one or in V6. I think it's important for you guys to kind of differentiate right bundle and left bundle. It's kind of expected from you guys. Right, we'll go back to the first example. So this is a patient who's coming in with mild chest pain. Their blood pressure is 120 over 80. This is their baseline. They're chest pain free. So they have, what's the rhythm?
Sinus rhythm.
Sinus rhythm, correct. Axis?
Left.
Left axis deviation, correct. And what do you guys think of the ST segment?
في depression في الاس segment في lead 2.
Lead 2, all right.
Okay. في B3, B2.
V3, yeah. What about V4?
Yeah, as well, B4.
Very
and
obvious,
B5.
V4, V5,
Yeah.
V6.
Yes.
So this is the same patient. In this ECG on the precordial leads, like V1, V2, V3, V4, V5, V6. This is the same patient, but now his blood pressure is 180 over 100. What changed? So how is this different? I'll go back and forth. So this is the new ECG, and this is the old ECG. New ECG. What is different?
I think it's more ischemia. There is more depression.
Yeah, there is profound ST segment depression here, right? V2 nasal, V3, V4, V5, V6. And previously, V4 can nasal about 2 millimeter, but it's an ST segment that you have to look for to see it. But then afterwards, when the patient had high blood pressure, there's really significant ST segment depression in all the leads. And if you look at AVR, the ST segment is even going up. So it's similar to that previous patient. This signifies large myocardium at risk. This is probably significant either left main or 3 vessel disease. Look at AVR here and AVR here. Tad bit up and significant diffuse ST segment depression. Make sense? Any
Yes.
questions? Perfect. All right. So what's the rhythm here?
Sinus.
Sinus, absolutely. Axis.
Normal.
Absolutely. QRS. So if you call this a narrow QRS, يعني I would understand, but this is actually wide. So if you look at V1, V1 looks wide. Why is it wide? Yeah, correct. Khalifa, صح عليك. Right bundle branch block. So this is right bundle branch block, right? So this is patient having chest pain. The blood pressure is 120/80. This is their next ECG. The chest pain is worse. They're sweating and their blood pressure is 90/60. So what changed? What's the difference between here? What's different between here and here? All the ECG and then new ECG. Guys, what happened? What are you noticing? I think you should have noticed that the heart rate is slower.
Heart walk, I think.
Yeah, but did you guys notice that the patient is bradycardic? So here versus this, the heart rate is a lot slower, or the rate is slower, right?
Yes.
Perfect. So whenever you see bradycardia, you should immediately look for AV block. So do you see AV block here?
Yes.
Okay, perfect. So first, second, or third degree?
Third degree, I think.
So if you're saying third, معناته you think that this P did not give us this QRS. And this did not give us this. This did not give us this. This did not give us this.
No, then.
Second type. I think is second degree type 1.
All right.
Sorry, there is no prolongation PR.
There's no prolongation. Therefore, we say second degree Mobitz type 2.
Mobitz type 2.
This one you can't actually tell. So we assume that it's Mobitz type 2. But this one? do you guys think? Rhythm?
Sinus rhythm.
Perfect.
I think is Mobitz type 2 as well.
Get into the habit of saying there is AV block, right? It just takes pressure off of you. So there is AV block. Good. Now, first, second, or third?
So for second degree, Mobitz type 1, I think 1 to 2, I think.
Okay, the majority is going for second. Yeah, I agree with second. Mobitz type 1 or type 2?
Mobitz type 1.
Type 1, correct. So if you look at this pause, compare this PR interval to this PR interval, this is shorter than this, therefore it's Mobitz type. Correct.
2 to 1 or?
It's actually variable, and it's not uncommon for Winkelbach to change. So here you have 3 to 2, so 1, 2, 3 P's for 2 QRSs. So when we say 2 to 1, we mean 2 P's, 1 QRS, right? So hina is different than hina. Hina we have 1, 2, 3, 4, 4, 3. So 4 P's, 3 QRS.
Okay.
All right. I think that's enough. It's about an hour for ECGs. I think we can stop here and go for coronary angiography. Do you guys want a break, or should we keep going?
As you like, Dr. Saad.
Okay.
I think we should continue.
All right. Can you see the screen?
No, we cannot.
Or now?
Yeah, now we can see.
All right, perfect. So, try to. We'll try to still make it as interactive as possible. So I'm sure you guys are really excellent with anatomy, probably better than the cardiologists. But these are just basic anatomies for the RCA. So it comes out of the right aortic sinus. Usually, typically, the right has a lower origin than the left, but not necessarily all the time. I would say the right is more likely to have some sort of anomalies, coming off the anterior wall or coming off anteriorly sometimes. It's very important for the angiographers, not so much for the surgeons. Most people are right dominant, and I think it is important to know the dominance. And the dominance is it's different. Every textbooks are different on what defines dominance. Some say it's the artery that supplies the AV node. Some says that it's the artery that gives the PDA, which I agree with that. Some says that it's the artery that supplies more myocardium. So if the circuit is really large and supplies large myocardium, then they would call it a codominant system. I think it's what gives the PDA. First branches of the RCA, conus and SA node branch. The conus supplies the RBOT. It's very important for angiographers because the RBOT is electrically sensitive. So if you inject into the conus, people commonly have VT-VF. SA nodal branch is usually the second branch coming off the RCA. The RCA gives the RV branches or the marginal branches, and that supplies the free wall of the RV, very important arteries, because occlusion of those arteries can lead to RV infarct, RV failure, which kind of clinically patients don't behave very well when their RVs don't work very well. And we really don't have very good solutions for it. The left system, so the left main bifurcates into LED and circ. Not uncommonly, we have a ramus. The LED, you know it as the interventricular groove, very important artery, supplies about 30 or 40% of the myocardium in the LV. We go by proximal, mid, distal based on the diagonals. So after the first diagonal, it becomes mid LED. After the second diagonal, it becomes distal LED. Same goes for circ, runs in the AV groove, parallel to the coronary sinus, supplies, gives OMs and variable supply. Sometimes it's small, sometimes it's big. So variable from 15 to 40% of the LV in a dominant circ. Definitely a dominant circ is really, really important and clinically underappreciated. So after the first marginal, for the RCA, after the first marginal, we call it mid RCA. And after the second marginal, we call it distal RCA. And after the bifurcation, it becomes a PDA and a PLV. Same for circ. So proximal, then after the OM or the PDA becomes proximal, mid, distal. LED after the septal or diagonal, depending on which textbook, but most people go with the diagonals as proximal, mid, distal. I'm not sure, I think you guys should know the views, but it's really more than knowing which are they. It's really just being able to recognize them and recognize the vessels. In general, caudal views show you proximal vessels. Cranial views show you distal part of vessels. And it is important to know which is which, like where is the LED, which view elongates the LED in this view, or which view elongates the circ in that view. For the left system, a minimum of 4 shots. For the right system, a minimum of 3 shots. Sometimes in people with renal dysfunction, we could take 2. 2 is the minimum angiographic shots for proper coronary angiography. So here, if you look at this picture, this is an areocaudal. So It's called, RAO because the spine is here. And in RAO caudal, we see that the circ runs here, while the LED runs on top of the screen. As you can see, because it's a caudal shot, we can clearly see the proximal part of the vessels. We cannot really clearly see the distal part of the vessel. This is AP caudal, with again the circ running that way, the LED running up here. This is a cranial view. So this is eleocranial, left main, LED running this way, circ running that way. So to identify LAO versus RAO, you identify the spine, where is the spine, and you flip it. You go the other way around. My favorite way is to really just look at the picture. Don't like look at the picture and know that this is what an eleocranial looks like. Similar to Kingsellman. So you see Kingsellman, you just recognize Kingsellman. You don't apply criteria. You don't do anything. You just recognize the pattern. So this is again, areocaudal, left main, giving you a circ and an LED at the top. The vessel that hugs the wall in the areocaudal is the diagonal, while the LED comes this way. So the diagonal continues that way, and the LED comes in the middle in an areocaudal. Why is it important to know the course of the vessel? Because if it's occluded, you would know that it's occluded. So here, we know that this is circ, this is a high diagonal or ramus, and we know that there should be a vessel running that way, but it's occluded. Same view, right? This is an areocaudal view. Another view, spider or eleocaudal, very good for the proximal segment of the circ, proximal segment of the left main, proximal LED, not really good for the distal LED, not good at all for the distal circ. So eleocaudal or spider view. Apicaudal, again, we can see the circ and the LED diagonal hugging the wall of the heart. The RCA, for RCA, we usually have 3 views. So straight LAO, straight RAO, and epicranial. So a straight LAO shows you the course of the RCA, the proximal, mid, and distal segment. It doesn't show you the PDA and PLV. The RAO shows you the mid segment very well. It shows you a different view of the PDA and PLV. Does not show you the bifurcation well. It does not show you the ostium well. Epicranial shows you the bifurcation very well, the distal RCA very well, and shows you the length of the PDA and the PLV. So here is an angiogram. So this is a femoral angiogram, right? Areocaudal. The catheter is selectively in the circ, so it's preferentially in the circ. So we can see that the circ is filling first. The circ runs in the AV groove, gives you OM1, which is small, gives you OM2, which is large, gives you OM3, and then gives you a left PDA right there. Then we can see that the left main is very short. The LED runs up here. We can see a stent, which is right there, patent stent in the LED, and then the LED runs that way, and we have a small diagonal coming in. As I said, since this is a caudal view, it's really good for the proximal part. You can't really comment on the distal part because it's going away from you. This is an AP cranial view. We know that it's cranial because we can see the diaphragm, and we know that it's cranial from the shot itself, right? Because I've seen AP cranial in the past, and this is what it looks like. So left main, we don't really see the proximal segments very well. They're overlapped because it's a cranial shot, but we can see the length of the LED, and we can see the mid LED, the distal LED, and we can see that it's clear. So patent stent, some mild ISR in the stent, but the mid distal LED is good. Do you have any questions on this? Are you able to recognize that this is an LED, this is a circ?
Yes.
Okay, perfect. All right, so cranial, just a different view. Again, because it's a cranial shot, we can't really see the proximal segments of the vessel, but it extends the LAD and it gives you an orthogonal view. So that mild ISR that we saw, we can appreciate it better here. So this is, I would say, mild to moderate. So we upgraded the disease inside the stent just because we took a second view. And this is clearly a left dominant system. This is a spider view of the same patient. We can still see the catheter is pointing and is actually engaging the circ. So it's filling the circ better. And then it's back filling into the LAD. The left main is very short. The proximal circ, the proximal LAD are okay. There is probably mild disease in the proximal LAD, but it's not very well opacified because the catheter is pointing to the circ. RCA, so this is an LAO cranial view. And we can see that the proximal segment, the quality is not great, but we can see that there's mild disease proximally and that there is severe disease in the distal RCA. And then the distal RCA bifurcates into a PDA running down and a PLV going straight. So in an LAO crani, the vessel that goes up is PLV, the vessel that goes down is PDA. And there is severe disease proximal to the bifurcation. RIO view of the same patient, and you can see that clearly the mid segment, you can see it very clearly, but the distal part of the vessel is not very obvious. And that disease that we just saw, you can barely appreciate it here. If you actually didn't see the previous shot, you might call this normal just because you didn't take a cranial shot. So in this view, you can still see that distal segment or that distal disease, but it's not as obvious, which is right there. This branch, RIO is helpful in figuring out what is going anteriorly and what is going posteriorly. So this branch up top is the conus branch. It's going into the RVOT, which is an anterior structure, and the SA node branch usually goes down. So a small non-dominant RCA. Okay. Whenever you guys are describing lesions, it's helpful to kind of talk about the length, how eccentric the lesion is, and really calcification. You can't really miss calcification. So if you have calcification, like if there is an angiogram and it's heavily calcified, that's a very important clinical thing that you have to mention, that it's heavily calcified or diffusely diseased versus not. Gonna go a little bit faster on this. So bifurcation lesions are important for interventionalists because stents don't do very well with bifurcation. And I think it's also important for you guys because if you graft this vessel and it's diseased, it might not actually backfill into this branch. You might have to also graft this. Let's say you have an LAD diagonal and the disease configuration is like this. If you only graft the LAD, you might backfill the diagonal. If the disease configuration is like this or like that, then you actually have to, or you might think of grafting both arteries. Medina classification is the widely used one. So we say Medina and it goes 1 versus 0. So this is a 1, 1, 1. What that means is there is disease more than 50% in the proximal part of the bifurcation. There is disease more than 50% in the distal native vessel. So this is left main, this is LAD. And there is disease more than 50% in this branch. Here we would say 1, 1, 0. Here we would say 1, 0, 1. Here we would say 0, 1, 1. We would say 1, 0, 0. And as soon as you hear this classification, you kind of envision or know what are we talking about. Dana classification is very easy to use, and it's the most widely used. Any questions on the bifurcation? This is for PCI mainly, but essentially this is what tells us how easy the lesion is to fix spontaneously. So we have type A, type B, type C lesions. And type A lesion is a simple lesion. You go in, you put a stent, very low risk. A type C is considered high risk if it's CTO, if it's diffuse, if there's a lot of calcium, if it's in a vein graft. So this, I would say, is a bifurcation, and I would say this is 100 in the distal RCA. Makes sense? You guys are familiar with TIMI flow? So TIMI 0, no flow. TIMI 3, normal flow. TIMI 1, slow flow, and there is incomplete filling of the distal coronary bed. TIMI 2, slow flow, but the contrast reaches the distal territory, but it just reaches slower than the other branch. So femoral angiogram, engaging the RCA, and then there is a linear filling defect that starts from the proximal RCA and extends into the mid RCA all the way to the distal RCA. This linear defect is likely to be a dissection. So this is, I don't know if this is a spontaneous dissection or a catheter-induced dissection. This is a dissection into the right coronary artery. Dissections are really problematic for percutaneous fix, because if you get into the false lumen and stent the false lumen, then you'll have no distal perfusion. And the dissections are usually, as I'm sure you know, they happen at multiple levels, meaning there is connections between the false lumen and the true lumen at multiple spots, which means that the wires can get in and out of the false lumen or in and out of the true lumen. So this is a severe lesion in the distal RCA. This is a right coronary guide, and we have a coronary guide wire all the way in the distal RCA. So left system, left main has moderate disease, proximal LAD has severe disease all the way to here. This patient is post-coronary artery bypass grafting. And we can see here that there is competitive flow. So the contrast gets in, and then there is something that washes the contrast. So the contrast gets in because of the injection. The injection is really high pressure. And then when the contrast gets here, and during diastole, it kind of washes down. That's because the lima, there's a lima to the LAD, that lima is patent. So from this injection, we can say that there is severe disease in the LAD, patent lima to LAD. I think you guys should be able to recognize this pattern, which is competitive flow. Same view, I think we've seen this angiogram. Epicranie, patent stent, mild ISR. So what are we looking at?
Lima.
Yeah, so lima to the LAD, patent, looking really good. Sometimes it's kind of difficult to know where exactly is the touchdown and a different angulation. So if you go more lateral, so part of LAO, then you'll be able to see and delineate exactly where is the anastomosis site. So what are we looking at?
I think SVG to RCA.
This is actually native RCA, not an SVG, and it's completely occluded. So it's occluded RCA. The way we know that this is the native RCA is branches. So you see those branches. I know it's big, it looks like a vein graft, but because it has this branch, and even this branch, Also, we know that it's an RCA because of the location. If you look at the backwash of the contrast, the sinuses or the aortic sinuses are filling. The SVGs are typically a bit higher around here. What do you think of this?
This could be an saphenous venous graft.
Yeah, so this is an SVG to a diagonal. It's a bit difficult to know where is the artery landing into. We know that this is the body of the vein graft. We know that it's landing right there. So this is the anastomosis site. And we will know that this is a diagonal. But typically to really delineate the vessel where you're landing to, you need two views. So you do this view and then you go epicranial and you confirm that this is a diagonal. So what do you think of this? Sorry.
Also. Vein graft as well.
Yes, so vein graft into an OM. So this is a vein graft, and this is the touchdown right there into these big two OMs. What do you think of this?
Yeah, I think this also SVG to RCA, I think.
Yes, so this is a saphenous vein graft into the RCA. Notice that it's higher. So look at the backwash. The coronary
eclipse and
valve is this. Then it is branchless.
And clips.
There are those things which I don't know what they are. I've never seen them in my life. Surgical tools. That's what we refer to them. We'll just cover some anatomy or some anomalies. So this catheter is engaging the RCA, right? And then we have things that are lighting up. So I'm going to freeze the image. So this is your right coronary artery. It's occluded, it should be running that way. And then you have this artery, which is an anomalous circ coming off the RCA. Yes, you guys agree?
Yes.
Okay. So the RCA here is totally occluded. It's filling slowly. So this is not a small non-dominant RCA. No, this is a branch. Those are marginal branches. And the true RCA is, you can see it faintly filling in here. Probably with the left injection, it fills up even more. What do you think of this? So what is this vessel?
RCA.
Yeah, so that's your right coronary artery. It's normal, no significant disease. It's a dominant vessel, right? Because this is the RCA and it's a dominant vessel, right? Gives you a PLV. What about this guy?
LAD, I think.
Yeah, that's an LAD. It's giving you septals. I hope I have another shot for it. Yeah, there is another shot. So this is the LAD. It's giving you septals and it's going to the apex of the heart with the stent and the LAD, and the anomalous LAD. So this is the LAD coming off the right coronary artery. What do you guys think of this? So what is this vessel?
RCA.
Correct. And what is this vessel?
It's going to the left system.
So this
LAD, anomalous LAD.
Circ, I think this one, that one.
I'll give you a clue. هو واحد منهم يا LAD يا circ. 50-50.
I can see two vessels actually.
Exactly. So which is which? So try to guess which is which. So you have this vessel.
This is a circ.
This is circ. And this one?
Is a LED.
Correct. So this, because it's giving you septals, that's number one. Number two is we said that the LED runs in the interventricular groove, right? So if you're looking at the heart, this is the RV and this is the LV. So this is the interventricular groove. This is the part that separates RV from LV. Therefore, this is LED. This is the lateral wall. Therefore, this is the circ. Make sense?
Yes.
Yes.
All right. So that's an cranial view, right? You see left main, and then we see this vessel. What is this vessel?
LED.
Yes, correct. So that's your LED. And then we see this guy, which is
RCA.
a circ. So that's your left circumflex, right? Then we have something here.
Leak. Fistula.
Yeah, I think that's a fistula. I can't really tell where it is, but I can tell that it's emptying in a chamber. So I'm going to guess that this is emptying into a pulmonary vein, and then the pulmonary vein is draining into the left atrium, and the left atrium is draining back into the LV. We can clearly see a fistula here, right? Could be directly draining into the left atrium, but it looks to me like it's draining into a pulmonary vein that is emptying into the left atrium. It's a bit tough. It's definitely almost impossible to figure out from one view, but definitely you should be able to recognize that there is a fistula right there, correct? And from the way it's emptying, you should be able to comment that it is emptying into a chamber, right? Does that make sense?
How did you know, Dr. Saleh? It's emptying into a chamber?
Sure. So if you look at the contrast, how does it collect and how does it clear? This is the contrast. So follow it, follow it, follow it. See how it's kind of stagnating in here? That tells me it is emptying into somewhere here, which is most likely pulmonary vein into the left atrium.
Okay.
Following the contrast.
Okay, thank you.
Excuse me, Dr. Saleh.
Yes.
What about allocating the BA, pulmonary artery, in such view? Can we?
Yeah, it's a bit tough, but essentially the PA, you need to follow the RVOT. Really, when we want to locate it, we usually access the femoral vein and put a Swan-Ganz catheter into the PA. So in here, if you asked me where is it in here, I would say it's in this region. You can't really pinpoint where it is exactly. And you definitely cannot comment on whether it's compressing anything or it's doing anything. If you really want to identify it, you either put a pigtail in there or you essentially put a catheter in there. And even then, you would opacify it and you would inject at the same time so that you can clearly see it.
Thank you.
Late filling here. If you keep your eye here, there is something that comes out right now.
Yes.
Yeah, so that's your coronary sinus emptying into the right atrium, okay? In the levo phase here. All right. So this is a post-op patient, right? And coronary injection, cryocrany, and severe disease in the proximal segment of the LED. Then we have this.
Looks like a
Aneurysm.
septal.
Yeah, so that's a small coronary aneurysm. And then there is significant disease in the LED. And then there is good distal target for the LED. What do you guys think?
Same coronary aneurysm.
Coronary aneurysm. Yep.
Big.
Comment on this disease. I'm not sure if it's actually true disease in the LED, or if the aneurysm is so big that it's actually compressing. So if you look at the quality of the LED, it looks like it's a healthy vessel, right? Looks like a healthy vessel. So I'm not sure if this is, good old atherosclerosis versus outside external compression by the aneurysm. If we put intravascular ultrasound, we can actually tell if this is diseased or if it's not. So if you put a catheter here and we give you good imaging, we will be able to tell. I think it's important because if you're going for a surgery and if you surgically resect this, that actually might fix the blood vessel without needing for grafting. So if you do intravascular ultrasound here, you'll be able to say to the surgeon, there's no need to graft this. So even though there is actually significant disease, you do not need to graft it because once you remove the external compression, you're all set. There's no need, the artery will be normal. But if there is atherosclerosis and you remove the external compression, nothing will happen. You still need to fix this bypass or stent it. This patient did not go for surgery. This patient underwent a percutaneous procedure with a covered stent that excluded the aneurysm. And with a covered stent, you really don't need to think much if it's because you're going to do it anyway to exclude the aneurysm, which will also fix the narrowing, be it either external compression or atherosclerosis. So, what is this vessel?
LED.
Correct. What do we have here?
I think we have straight segment. I think we have intramuscular LED.
Exactly. So this is myocardial bridging. So that's bridging or an intramuscular course of the LED. During systole, contrast becomes squeezed. So here, this is systole. You can see that the artery is squeezed so much, and this is, I'll try to pause it in diastole. This is diastole, and it's not squeezed. So systole, diastole, and it's kind of wide. Another view, you can even appreciate the same phenomenon. So compression of the LED. This sometimes gives you chest pain, but it's a benign thing. It does not result in MI or narrowing. It's very challenging, I guess, or I've been told, to graft this because you need to free it first. So what do we have here? We have a temporary wire going into the RV, old stents into the RCA, coronary guide, and intra-aortic balloon pump, right? And then a sub-selective injection into the left coronary cusp. And we can see that the left main is open. That's pretty much all we can comment on. And then what do we have here? So same patient, we're injecting into his coronary. And then there is left main. Do you see any disease in the left main? That's the left main. It's free of disease, right? And mild disease in the LED. Anything else? I'm waiting for you guys.
Disease circle also.
Disease, yeah, there is definitely disease in the cell. Anything else?
The heart shadow.
Yeah, the heart shadow is funny, right? This is the heart shadow. And then you have almost like a double contour, right? You have this, and then you have this. Is that what you meant?
Yeah, tamponade or
So there is fluid collecting to the pericardium. That's why the patient is tachycardiac. And if you look at the circ, there is this. This is contrast exiting the circ and collecting into the pericardium.
Perforation.
Perforated circ, and that patient is in clinical temperament. They need to be drained. So they put a wire, they put a wire here in order to deliver a balloon. Once you deliver a balloon, you inflate it, and that stops the bleeding. And then now you have a catheter. So this is a pigtail catheter into the pericardium. So it's a percutaneous catheter from the subxiphoid into the pericardium. Thank you so much. I really apologize again for that delay with 2 days ago. And I'm happy to take any questions if you have any questions.
Thank you so much, Dr.
Thank
Saleh.
you, Dr. Saleh.
Thank you, Dr. Saleh. Thank you very much.
الله يعطيكم العافية وأتمنى لكم التوفيق.
مشكور يا دكتور.
Thank you, Saleh, for your lectures, and hopefully we'll see you again soon, inshallah. So by this, we'll conclude our session for today. See you next week, inshallah. Thank you very much.
Thank you.